yanzu ka je ka zanna ba yanzu ka lokaci ko ba sai ka zanna na ga muke wuce ka yanzu kai ba sarki ma ka hada fadawa ba wallahi gari
kashi afu zan raka shi cikin gida to sai na gaba kafin shi lami da kai kafin shi lami da Allah kafin shi lami da yan uwan shi kata kata ne.
Okay. Good morning, everyone. Thank you so much for joining us in the last module of the neurophysiotherapy series of workshops. So today is the last one in the neurophysiotherapy series. We are going to be looking at assessment and management of Parkinson's disease. Very quickly, because we are going to focus more on the hands-on, or the practical today, but I think it's important to review some anatomy and pathophysiology so that we'll understand the symptoms and signs of Parkinson's disease, how they come about. So I'm just going to go very quickly, and that's why I don't have slides for today. I'm just going to go very quickly to explain the pathophysiology, anatomy, and then we'll look at some of the cardinal signs of Parkinson's disease, and then other related signs and symptoms. Then we'll now go ahead straight into the assessments. I have two people here, just like the last 2 weeks, that are going to help me with the practicals, and we're going to be demonstrating how to assess the symptoms and signs of Parkinson's disease. So as I've said, if you remember the first lecture that we had, and the first module in the series, we discussed anatomy and physiology, how systems of the body, the parts of the nervous system, work together to bring about movement, starting from sensory, where we looked at the visual system, the proprioceptive system, the vestibular system, how they gather information about location of objects in the environment, the position of the body parts in space, the parts that are going to move, their position in space. The brain needs that. And we said all this information, sensory information, is synthesized in the prefrontal cortex of the brain. And when that is done, then the premotor cortex and the supplementary motor area will now select the different patterns that are possible. And then we said the basal ganglia will now select one out of the many options of patterns of movement that are possible. So you want to kick a ball. How many patterns of movement are possible? Do you flex your hip, flex your knee, and then you kick the ball? Or do you need to abduct the leg and then you kick the ball? So there are components to each pattern. And therefore, the pattern will have components, different components. So those patterns, different patterns that are possible, that are options, that are choices that the brain has to use one out of those many for the task to be carried out. It is those patterns that the basal ganglia will select one out of many. So very quickly, we are going to look at how this is done in the basal ganglia. So I'm not going to go into the remaining part of the anatomy and physiology of movement. I'm going to focus only on what happens in the basal ganglia. So the premotor and supplementary motor area, as I've said earlier, has selected what patterns are available. So that is at the level of the cortex, because the premotor and supplementary motor area are in between the prefrontal cortex and the motor area. So it is in the cortex. So that information about the different patterns that are possible will come down to the striatum of the basal ganglia. If you remember the second module that we had on neuroradiology, I remember how the parts of the basal ganglia are stationed around the ventricles, the lateral ventricles, the third ventricle. If you remember, they are positioned around those ventricles. They don't look like what is here. It's just for simplicity's sake, for us to be able to understand how those parts of the basal ganglia work together to select one out of the many patterns that have reached it from the cortex. This is just what I want to demonstrate here. This is not the exact positions of these structures in the brain. But if you recall the pictures, many pictures that we showed when we did that radiological investigations, myself and Dr. Abba of radiography, you remember the exact locations of these structures. So the striatum is the first point of entry. The information gets there from the cortex. And while it's in the striatum, the substantia nigra pars compacta releases dopamine, and this dopamine gets into the striatum. It is the dopamine that works on the information that is in the striatum to be able to now help it either to go through an indirect pathway or to go through a direct pathway. So let's assume we have 20 different patterns that are possible for the individual to carry out the task. Each pattern has different components, and the components are joint movements. So flexion in the shoulder, extension in the shoulder, abduction in the shoulder, flexion in the elbow, extension in the elbow. These are all components, and each pattern will have a different set of components. So those components for each pattern are unique. And this is what is available to the striatum. So substantia nigra pars compacta is now going to be released to go to the striatum, and it will influence some activities in the striatum that will help for one out of the 20 patterns to now be sent through the direct pathway. And therefore, that will be facilitated, and it will now come to the globus pallidus. The M is the medial, the L is the lateral. So it will come to the globus pallidus and the substantia nigra pars reticulata. So this is substantia nigra pars compacta. It releases the dopamine that helps in selecting and facilitating information about one pattern that comes through the direct pathway to the globus pallidus and the substantia nigra pars reticulata, while all the remaining will now go down through the indirect pathway, where it will reach the lateral globus pallidus and the subthalamic nucleus. And from there, it now goes to the globus pallidus and the substantia nigra pars reticulata. So what this means is that there is information about what pattern should be used in the task. There's also information about what patterns should not be used in the activities. This is what helps the brain to be able to now send impulses to the muscles very quickly and for the muscles to quickly be activated and do the task. If the basal ganglia does not select the appropriate pattern, one out of the many, then there's going to be confusion in the system. What is this confusion? An example, I gave an example one in module 1. I said you are going to a village. There is a path. As you are moving on the path, you reach a point where there are 3 different paths that emerge from that one. They reach to different locations of the village. And where you are going to, you need to take only one of those 3 paths to go there. As you get to the end of that one path that divides into 3, if you don't have a map, or you don't have a guide, or you don't know which one to pick, you are going to stop there and you will slow down. And you will now be thinking, which one do I take? And that is going to slow your movement towards your location. But if you have a map, or someone is there to say that, look, we go straight, or we go right, or we go left, you don't even need to stop at the junction. All you need to do when you get to the junction is just to quickly take the direction that is appropriate to go to your location, and you move, you get to your location. And that is one of the reasons why you have bradykinesia, slowness in movement, because the brain is confused. There are many patterns that are possible, but the basal ganglia is not selecting one out of the many. And therefore, the brain is confused. Which pattern do I use? And that is where the person gets stuck, cannot move, all those issues of freezing of gait and the fascinations and the bradykinesia. We see all those things because the basal ganglia is not able to select one out of the many patterns that are possible. So if there are other abnormal movements also that can come in the basal ganglia, just selects what is appropriate and sends it back to the cortex, motor area of the cortex. But it does that by sending it through a relay center, which is the thalamus. The thalamus is a relay center. It's a sensory relay center. From the basal ganglia, the information will go down through the thalamus, and then it will now go up to the cortex and exactly the motor area. And that is where the motor area will now say that, okay, we have one pattern. And that pattern says there should be flexion at the shoulder, abduction at the shoulder, flexion at the elbow, flexion at the wrist, and any other component of movement. And the area of the brain, motor area, the homunculus, the part of the homunculus that takes care of the shoulder and that takes care of the elbow and wrist will be the one that will be activated. And when it is activated, then the movement takes place as quickly as possible because there is no other pattern that is being considered because the basal ganglia has suppressed, has inhibited all the other patterns and is just allowing the motor area to activate areas of the brain that will bring about movement in this pattern, one pattern that has been selected by the basal ganglia. So this is what is happening. And it's important to understand these concepts physiologically and anatomically so that we'll be able to know when we see things in patients, why they happen, what happens to the brain that makes it to happen. So in Parkinson's disease, what happens is that this substantia nigra pars compacta does not produce the dopamine. And without dopamine, you are not going to have this activation of the indirect and the direct pathway. And if you don't have that, you are not going to have one selected that goes to the globus pallidus and substantia nigra pars reticulata, and you are not going to have the thalamus send back one to the cortex for it to be activated or implemented. So this is what happens in Parkinson's disease. And that is why levodopa is given to patients that have Parkinson's disease. What the levodopa does is to help the body to produce that dopamine. So the substantia nigra pars compacta cannot produce it. The levodopa or any other drug that produces the dopamine is the one that is going to now bring in dopamine into the system, and then it acts on the striatum to do those activities that we see. And that is why there is what is called on and off levodopa. When you take the drug, dopamine is provided to the system. You see the patients have fastness in movement instead of slowness of movement, bradykinesia. You see the rigidity reduces and other symptoms reduce. But when the patient is not on it, hours after the action of the levodopa ends, then you see the symptoms come back. And that is why the patient has to be on the drug within the period that they are told by their doctors to take the drug. It's one of the things that physiotherapists in the UK enjoy now. When you want to treat a patient and they have the slowness in movement, the rigidity, and you will need to do your exercises when the patient is on levodopa. And sometimes when the patient comes, you have to send them to a physician, take the drug, come back to you, you do your activities. They now have legislation that physiotherapists can administer some selected drugs to reduce the burden on other health professionals and be able to provide the patient with services that they require without paying for two professionals at the same time, have waiting time to see two professionals at the same time. These are some of the things that they do in the UK to make things easier for patients. So this is just in a very small summary on what happens in the basal ganglia and why the basal ganglia is important and what happens that leads to the disease called Parkinson's disease. Now, the next is to quickly list some of the manifestations, some of the clinical features of Parkinson's disease. The 4 cardinal signs of Parkinson's disease, as we all know, is bradykinesia. That's the primary one, number 1, bradykinesia. Then rigidity, tremor, and then postural problems. Some texts will say when you have bradykinesia, primarily there must be bradykinesia before you diagnose Parkinson's disease. Remember, I said this is medical diagnosis, not physical diagnosis. But it's important for us to understand what comes to us. So we are not the ones that make the diagnosis of Parkinson's disease, because that is an organic pathology. If you don't have substantia nigra pars compacta, dopamine in the substantia nigra pars compacta, it is not a movement impairment issue. It's an organic pathology. And since it's a drug that gets in there to supply the dopamine, it is a physician task, not a physiotherapist task. But it's important for us to understand what comes to us as a diagnosis, and that is why I'm explaining this. So you have bradykinesia primarily, must be there, and then you can have any of the other 3, either tremor or rigidity or the postural problems. So these are the 4 cardinal signs of Parkinson's disease. Now, Parkinson's disease usually will come with some other problems apart from that of the substantia nigra pars compacta. So you're going to have problems that stop or hinder the release of some substances such as norepinephrine and other substances that are required in some activities in the body. And this is what leads into problems with depression, problems with apathy, anxiety, and other problems like that. And also you might have systemic problems such as blood pressure changes and other changes, all because it interferes with the production of norepinephrine and other substances that are required to regulate the systems of the body. Now, because of postural problems and the slowness in movement, when there is slowness of movement, the body wants to go forward, but the legs cannot take the steps fast. And that is why you will see that posture of festination, where the body is going forward and the lower limbs to keep up with that projection of the body. And it can't take long steps. It keeps taking very small steps, but very fast. And the hands are kept there aside because they are also not moving properly. And that is when you see that Parkinsonism gait and posture. So these are also some of the things that you can see. Another thing that you see in Parkinson's disease patients is the issue of freezing of gait. So the patient just gets stuck and the foot as if it's glued to the floor. It cannot lift. So it occurs more when the patient is trying to turn around or when they are passing through a doorway. So usually it comes more. But in a severe case, even when they are walking in a free space without turning or going through a door, they still have such a problem. Now, one of the things that Dr. Badarup will come later to talk to us about will be the issue of what do you give as cueing to help patients. Now, I don't want to preempt what he's going to present, but the fact that we are discussing the anatomy and physiology, I just want to explain what happens anatomically and physiologically when you give a cue. So the brain is supposed to give one pattern out of many, but it doesn't give. If you have lines drawn on the floor, or you have a stick that you give to the patient that has a light at the end of the stick, or you ask the patient to go on a bicycle, to ride the bicycle, each of these cues will help the brain to get a pattern. And that is when a pattern is selected. So if, for example, you have lines drawn in front, the lines are going to influence the patient to know what pattern to use to step on the line. And therefore, a cue has led into selection of a pattern that the brain naturally will not be able to do. You will see patients that have stuck to the flow, the freezing of gait. You just put them on a bicycle and you will see they'll begin to ride the bicycle. Why? Because the pedal of the bicycle can only go in one direction. And that is what is going to give the brain a particular pattern. Because you can't ride a bicycle with many different patterns. The wheel is there, can just go in one direction, and therefore it makes the brain only to select that direction. When you give a patient a stick with a light at the end of it, whenever he puts the stick on the floor, the brain knows that the leg needs to go to where the light is. That provides only one pattern to the brain, and the brain now follows suit, and it does that. And that is why the issue of cueing is a really very, very important concept in management of patients with Parkinson's disease. Because what the brain cannot do in selection of pattern, the cues give that pattern that is required. So this is just in a nutshell some of the symptoms and signs of Parkinson's disease. I'm not going to make a long presentation on that because we will all spend a lot of time on just theories. What I want us to do now is to just go into the practical. And there are many outcome measures that are used. I'm going to start with the Unified Parkinson's Disease Rating Scale. Unified Parkinson's Disease Rating Scale. I used this scale in my PhD because my PhD, I was looking at how patients with Parkinson's disease and stroke, both Parkinson's disease and stroke, but how they turn around. So the coordination of their body segments when they turn around. And I categorized the patients according to their UPDRS, the Unified Parkinson's Disease Rating Scale. The one that I used that time, which was around 2010, 2011, it has been updated. It was simpler, it had less information, but this one has come with much more information added to it. But it has sections. It has sections looking at the areas of depression, the apathy that I mentioned that can come, and also motor area, motor examination, but also motor examination that is related to activities of daily living, and then a number of other sections. But because of the fact that there are 4 cardinal signs, I'm going to focus more on the motor examination that reveals the presence of tremor, rigidity, bradykinesia, and postural problems. So we'll start with that. And if time permits, then we'll look at the other sections. But the other sections are much more straightforward because it's just a question you ask the patient, and then they give you an answer about the issue of feeling depressed, anxious, and having an apathy, and other things that have to do with such issues that are part of what you see in Parkinson's disease. So we'll start with that. Then after that, we are going to look at balance. So there's a particular balance outcome measure that is related to Parkinson's disease. We'll pick that, even though you can use others that are used in stroke and other neurological conditions, but I'm going to pick the one that has been shown, possibly even developed for Parkinson's disease, and has been shown to be valid and reliable for use in Parkinson's disease. And then we'll look at some other things like assessment of freezing of gait and fear of falls, because they have a lot of tendency to fall. So we'll do assessment of how do we know that this person has fear of falls or had the risk of falls, so that we can be able to avoid those things as we manage them. So all these things put together will give us a picture of what the patient's problem is. And then the second session, Dr. Badori is going to come in to now talk to us about how to manage these symptoms and signs that we have seen in patients that have Parkinson's disease. But before we go to the practical, just want to open the floor for discussions. Have people seen Parkinson's disease patients in the clinics? What outcome measures have you used in treating, in assessing these patients? Just like we did in the last 2 sessions, let me open the floor for discussion on that. So you can either raise your hand or you can post on the chat forum. Okay, yes, Najib Sani. You can unmute and speak.
Good morning, sir. Good morning, everyone. It's been long. I'm very happy to be back. Actually, there was a patient that was referred from psychiatry, so physiotherapy, due to the movement pattern, but they are actually querying dementia uh, and depression in the patient. But when the patient came to psychiatry, we actually saw some signs, some motor signs, the bradykinesia and the freezing gait, and also the rigidity. So that was in 2022. So we actually use PDRS because my HOD is a fan of outcome measures. So then we were able to pick out the problem, that is the bradykinesia, also the how will I call there was also hypertonia in both limbs, lower limbs. So and the man is when you talk to him, it takes long for him to understand. So what I did that time for him to move faster, or my spend minutes from the waiting area to the gym, it takes him time to walk. And he uses before coming, he was already using a walking frame since from home. So what we do is started using pattern like you say queuing. I would like to say, okay, follow my voice, 1, 2. So he just put his leg. When I say one, he move one leg. And when I say two, he move the other leg. I think that was the only way. Then also we use this stepper, high HSC stepper for him because he could not understand movement. So I think the only thing he could do, like you said, were things that involve uh moving both legs at the same time. And then when it comes to cycling, people move both legs. It's a single pattern of movement, not like walking. Walking is more technical than either riding, cycle, or moving on the stepper. I think that was what after some time I think they refer him to because his children are in Abuja, so they have to move him to Abuja because the wife was like they are both elderly, cannot continue to take care of him. So I think that was
Okay.
they stopped coming from physiotherapy and they moved to Abuja. I think that was all. But I think we got some good results. He could follow patterns at the end of like the mood. He could follow patterns.
Okay. Thank you very much, Najib. Okay, maybe it was the network. No.
Thank you, sir.
Okay, thanks a lot. Actually, you just let me remember two things that are very important. That let me add them before we move forward. The differential diagnosis. Now, if you remember the first module that we had, I think we discussed during history how you are able to narrow down from the neurological system to a category of a neurological system. As that is to say, is it vascular in origin? Is it degenerative in origin? In nature, or what category? Is it inflammatory? And one of the questions there, we said onset of the disease. So if the onset of the disease is acute, meaning within minutes or hours, the patient's symptom reaches maximum, we said it is more of vascular in nature. But if it takes months, which is chronic, the onset of the disease is chronic, it takes months, then it is more likely to be a degenerative condition. The second question is about the pattern of progression, whether it keeps getting better or it continues to get worse. If it's getting better, it's vascular. If it is getting worse, it's degenerative. Now, you can have Parkinsonian symptoms. If a patient has stroke and the vessels that supply the basal ganglia are affected, then you can have Parkinsonian Abdurrahman Abdullah. I think the admin needs to help us with the coordinated muting people. I just had to claim and mute. Yes, so you can have, say, tremor or bradykinesia or something like that, but it's not a degenerative condition, and therefore you can't call it a Parkinson disease. It is still a stroke. The moment the vessels that supply the basal ganglia are sorted out, then you have those symptoms go. So if it is acute and the pattern of progression it's getting better, then it might not really be a degenerative condition like Parkinson's disease. So it's important to take note of those things. I remember we saw a patient in which one of the team members called our attention to the fact that when she was assessing the patient, she realized that it was an acute case and it was getting better. And therefore, instead of thinking of a diagnosis of Parkinson's disease, we thought more of a stroke. But these are cases that will require referral. When you do this, this is just like a systems review. So you don't go ahead and diagnose whether it is Parkinson's disease or it is a stroke, but it is important because your treatment will depend on what the source is. If it is vascular, the way you treat will be different from if it is a degenerative condition. So thank you so much. Another thing from what you have said that I remembered is the issue of other areas that need to be assessed. So speech, facial expression, all these are assessed in patients that have a Parkinson's disease. Thank you. On the chat forum, I can see Mr. Akinya saying time up and go outcome measure is used. So I'm wondering, is it that people are not using outcome measures or we are not seeing patients with Parkinson's disease? Because last week and the week before that, I saw many outcome measures be listed, but today I'm only seeing one. Is it that we don't use outcome measures or we don't see Parkinson's disease? Please let me know what's happening because I can only see one response out of over 60 participants that we have on the forum. So what's happening? Is it that we don't see them, we don't see patients, or we don't use outcome measures? Hey, can you hear me? Is it that okay, TUG test 2. Oh, okay. So time out and go test. Okay. So that's for balance. Yes, but we know that the cardinal signs, everyone that sees Parkinson's disease patients knows that the cardinal signs are bradykinesia, tremor, rigidity, postural imbalance problems. What do we use to be able to assess those? What do we use to assess those? We use FIM. Okay. FIM, is that functional independence measure? Good. So TUG FIM. It's a rare occurrence on our side. Yes, I must say that. Only in 2016 and 2022, 2 patients so far, but we used UPDRS. Okay. So Unified Parkinson's Disease Rating Scale. In the UK, they see more Parkinson's disease patients than stroke patients. But I can see in Nigeria, what I don't know is it that there are more stroke patients than Parkinson's disease patients, or is it that the awareness does not make them to come to hospitals? I don't know. But that's something that we need to find out. I haven't seen one for many years. Oh, okay, that's okay. And the locations matters. I remember one very senior physiotherapist saying that he never saw Guillain-Barré syndrome until he went to one part of this country, and that's when he saw Guillain-Barré syndrome. So it's not it's a rare occurrence in some parts of Yes, sorry, I think I lost the network. So we are going to start. Aha, Hoen and Year. Yes, wonderful. That's another very good one. Hoen and Year. But you do the UPDRS, and at the end, the result of the UPDRS is what is going to help you to do categorization for the Hoehn and Yahr scale. We have more stroke patients than, yes, definitely, more stroke patients than PD patients. So we are going to start with the practicals. And as I've said, we'll start with the UPDRS. I'm going to share it, and then we'll have someone that will help us with the cameras. We're going to use the computer. If you don't see clearly, just let us know so that we'll go back to an iPad that he can be able to move more freely. So let me just quickly share the. Yes, so this is the UPDRS, Unified Parkinson's Disease Rating Scale. As I've said, we are going to start with the motor examination. Okay. Yes. So this is the motor examination. This is part 3 of the Unified Parkinson's Disease Rating Scale. I mentioned the issue of being on and off levodopa. So I'm not going to go back to that. It's very important to record while you are assessing patients using UPDRS, whether patients are on or off levodopa. Usually when you say on or off, there are patients that take the levodopa, but they don't have relief of the symptoms. So they are off levodopa, so they can be on levodopa when they take the levodopa, and it helps them to have that slowness in movement changes, and they do normal movement, near normal movement, and also rigidity and other things will be good. So that's on or off. In another definitions, usually they will say when you don't take it for a while, you are off levodopa, and when the effect of the drug is on, say you have taken it after 1 or 2 hours, the effect is there, say you are on levodopa. But whatever it is, it's just for us to be able to know the situation of the patient, because you can assess and have a score when the patient is on the drug and it has an effect at that point, and the score will be different when the patient is not on the drug, or maybe they have taken the drug after 3, 4, 5 hours, the effect of the drug is not there, they will have a different score. So it is important to take note of the state of the patient before you do assessment. So you ask if the patient is on levodopa. So yes or no. If yes, meaning since last levodopa dose. Very important. Are they on levodopa? If they are on levodopa, when did they take it? So how many minutes since they took the levodopa? So let us start with the first item under motor assessment. In this, you are going to have a discussion with the patient. Unfortunately, we don't have the PD patient, but I will explain the scoring so that if you have one, it will be easy to be able to pick up which of the score that you are going to have for the patient. So you start having discussions with the patient, and you observe the speech of the patient. If there is no speech, score of 0. Now, in 1, there is loss of modulation. Now let's talk about the tone. We see there is a tone. When you want to emphasize something, or you are surprised, wow, what did you see? The tone will go up. That's a pitch. Or if you want, oh, come on, why did you do this? So the tone will come down. As you speak, emotions and expressions, you want to express yourself. The tone does not stay at the same level. It's a pitch. It goes up and it goes down. So this is the modulation. Meaning, so some patients, even with emotions, they maintain the same tone. When they are surprised, they maintain the same tone. When they are angry, they maintain the same tone. When they want to convey something that is urgent, they convey the same tone. So that is when they have a loss of modulation. The volume, I can raise my voice higher and the voice can come low. It's not about the tone. Because you can maintain the same tone, but with a higher volume or a lower volume. But the tone is there. There is no pitch. It doesn't go up and down as you speak, even though you have the same volume. So you either have the modulation, that is with the tone, the pitch not there, is just a monotone, you just have one tone, or you have the volume changes, or you have diction, that selection of words. There are some words that you use to make emphasis. So the use of words is what is called diction. But still, all words easy to understand. So the patient speaks, you can understand everything the patient says, but that tone is maintained at one level. You don't have change in pitch, going up or down. And the volume also is low, but you can understand the patient fully. You give a score of 2 when you have loss of modulation, diction, or volume with a few words unclear. So overall, you can understand what the patient is saying, but there are some words that are not clear that you can't get that, more with diction. So you then give a score of 3 when the speech is difficult to understand, to the point that some but not most of the sentences are poorly understood. So in 2, it is words that are not understood. In 2, it is words that are not understood. In 3, it is sentences that are not understood. Some sentences are not understood, but generally you can have a conversation with the patient. While with 4, you have most speech is difficult to understand or unintelligible. So it's a major thing in 4. So that is speech. Very important to assess that in patients that have Parkinson's disease. Then face expression. Observe the face of the patient for about 10 seconds. Usually when you are discussing with someone, or when he's just sitting looking at you, you find out that either you blink or you smile or you look away. These are some of the things that change your expression. You don't just sit blank and masked, as if there is a mask there. When you have the mask, nothing changes. You don't move your mouth, you don't move your nose, you don't blink, and you don't smile, nothing happens. So in patients that have Parkinson's disease, at the stage of 4, it's just like there is a mask in the face and you don't see any changes. So you give a score of 0 when you have a normal facial expression. So you smile, you blink, sometimes you do things with your face. So that's normal facial expression. You give a score of 1 when there is minimal masked face that is manifested only by decreased frequency of blinking. So you know the frequency of blinking that is normal. So sometimes the patient will not blink much. That's part of the masked face. 1 is blinking. So it's decreased frequency, but it is there. It's not that it is completely not there. It's there, but the frequency has reduced. You give a score of 1. A score of 2. In addition to the decrease in blinking, you have the masked face present in the lower face as well. So namely, fewer movements around the mouth. So usually as you sit, you see movement. You can pat your mouth, you close it, you can smile. Even if you are not discussing anything with people, you see changes in facial expression Someone is talking to you, you are not saying anything. They say something, you smile. They say something that's sad, you frown your face. So these are things that you see, but in a patient that has Parkinson's disease, no matter what is being said around, no matter what happens around, they have a blank face and they don't blink very well. So this is 2. With 3 is moderate masked face with lips parted. So when you sit down, your lips are closed. But in Parkinson's disease patients, the lips are parted. Even when they are at rest and they are not speaking at all. So, and it's some of the time, not all the time, that the mouth is parted. So they are sitting blank face, masked face, and the mouth is parted sometimes. While in 4, they have the masked face, no blinking, no smiling, no movement around the mouth or any other part of the face, and the mouth is parted all the time. This is a score of 4. Then rigidity. With rigidity, you are going to, first of all, there are 2 ways that you do the assessment of the rigidity. One, you just move the joints, just like you do in modified Ashworth scale. But in this one, they recommend that you move 2 joints. In the upper limb, you move the elbow and the wrist, while in the lower limb, you move the knee and the hip at the same time. Now, if you do that movement and you don't feel any resistance, that is what is called the activation maneuver. And the activation maneuver is when you are moving the right, you ask the patient to do an activity with the left. Either they keep pumping the hand or they keep tapping their knee with the hand. That is what is called an activation maneuver. And while you are doing that, you now do the movement. So for example, I'm going to assess the right side. So my hand, I will support the elbow. Very important, because you don't want them to put to put in effort in holding the arm. That might be why they will have resistance. So you support, so just relax. I'm going to hold the hand. You support around the elbow. You hold the wrist so that you can be able to move the wrist with your right hand, while your left hand will support the elbow. And therefore you move. So maybe you can start with moving the wrist to see if there's any resistance. And also you move the wrist and the elbow. Move the wrist and the elbow. So you feel resistance. Then we are going to do the scoring. But let's now do the activation. I want you to open and close, so raise it so that you can see. Not too much, so that they can see both. Yes, that's one. So I want you to close and open. Yes, pop, exactly. Then I move. So if there was no resistance earlier, it's possible that with the pumping, there might be a resistance. Another thing is tap your, yes, just keep tapping, keep tapping, keep tapping. Yes. I will move so that I will feel if there is any resistance. So you do that on the right hand, you do that on the left. Then for the lower limb, the same thing. The concept is the same. You don't move. You use your left hand to hold the knee. Then you use your right hand, start by moving the ankle. Start by moving the ankle just to feel if there is any resistance. And then you move the hip and the knee. Move the hip and the knee. And then you'll feel if there is a resistance. If there is no resistance, then you do the activation maneuver. You can still use the hand, tap. Or possibly use the other leg to tap on the floor. But that would be difficult because you are moving the right limb already. So this is how you do the movement. Let's look at the scoring, because the scoring is what is very, very important apart from the procedure. So when there is no rigidity at all, whether with or without activation maneuver, you give a score of 0. You give a score of 1 if there is rigidity only detected with the activation maneuver. So when you do the movement, no rigidity. But when you are doing the movement and they are doing the activation maneuver, you feel the resistance, you have a score of 1. You give a score of 2 when there is mild rigidity detected without the activation maneuver, but full range of motion is easily achieved. So without the maneuver, but you can have full range of motion. Rigidity detected without the activation maneuver, full range of motion is achieved with effort. Then rigidity detected without the activation maneuver and full range of motion not achieved. So if you see this scoring is similar to the modified Ashworth scale that we did. It's all about how much of resistance do you have, and also whether the resistance is throughout the range of motion or not. But an addition in this is the issue of the activation maneuver or no activation maneuver. Another thing that is also important to note, the difference between rigidity in Parkinson's disease and spasticity in stroke is that in stroke, spasticity is velocity dependent. That is why we do the TADU, you use the TADU scale, that you use 3 different velocities, and it's going to yield different resistance. But in rigidity that comes with Parkinson's disease, even if you use different velocities, you are still going to have the same outcome. So that is rigidity, and this is how it is scored. Now, because I'm using the video to be sure that you can be able to see, I'm not seeing this side of the screen. And just if you go back, you'll see that for facial expression and speech, you only have 1 box because the face is just the face. But when it comes to rigidity, you are going to have neck, because you are also going to move the neck to be able to see if there is any rigidity. Then the right upper extremity, so right upper extremity. Then you now come back to the left upper extremity and you test it. Then you go to the right lower extremity, you test it. Then you go to the left lower extremity, you test it. And this score of 0 to 4 is what you give to each of those parts of the body. So very important. And you can use this document as you are doing it. You just enter 2, 1, 3, like that. You give the scoring. It's very possible that you may have rigidity on one side and not on the other. When we come to deal with Hohen and Yahr scale, someone mentioned it, and I said it's an outcome of UPDRS assessment. So when we finish, we are going to see the Hohen and Yahr. One of the items will say it is unilateral, so there is affectation, but it is unilateral, and things like that. So it's important to assess each and every limb and part of the body that is there on this side. So I'm not going to continue to talk about this part of the document. In fact, it's even hidden because I'm looking at the camera to make sure that you can be able to see what I'm doing. But that is the concept. You need to fill in all the parts that are there. So this is rigidity. Let's now look at finger tapping. Rigidity is assessing rigidity. Finger tapping is assessing bradykinesia. So bradykinesia. Can you give me feedback? Can you hear me well? Can you see what we are doing, or do you need anything to change? Please just let me know before I continue. Can you hear me? I had someone speak. Okay, so I can see you clearly. We can hear you loud and oh, wonderful. That's good. Oh, that's good. Oh. Okay. So finger tapping. So what I want you to do, you are going to tap your finger like this and fast. So it should be full range and fast. So as fast as you can and as high lifted as you can. Yes. So maybe use this one so that they can see the 2 fingers. Yes. Use this one. So as fast as you can. So there are 2 things that can be observed when this activity is done. Number 1 is the amplitude. So how far up can he raise the index finger before he taps the thumb? That's number 1. Number 2, the speed. So maybe we start fast and then it will begin to slow down. And that's what is called an arrest. So it's not just slowing down, because slowing down, it will continue, but it is slow. But an arrest is when you start and it stops. And then at a later time, it continues. So there are three things. There are three things that you observe. Number one, the amplitude. Number two, the speed. And number three, the arrest. So when you observe those things, then it will not help you in the scoring. 0, no problems. Yes, so 0, no problems, meaning you have good amplitude, the speed is good throughout, and there is no arrest. You give a score of 0. A score of 1, any of the following. So you are going to have 3 things. Any of them that you see out of the 3 will give you a score of 1. The first is the regular rhythm is broken with 1 or 2 interruptions. So that is the arrest. So as you start, there is a rhythm. So the rhythm is broken because of the arrest. So it's broken with 1 or 2 interruptions or hesitation. Yes, so that's another word that they use, hesitation or arrest. That's why I brought another line to you. So, yes, so the second is the slowing, that's the speed. So as they start, then it starts to slow down. So it starts fast, and then it begins to slow down. It slowed down. So it is not arrest, there is no hesitation, but it's working, but only that the speed has reduced. Then the third is amplitude decrement. So it starts from there, but now it begins to come, the amplitude reduces. Maybe just very close, that's where the tap is seen. So this is, so usually you ask them to do 10 taps. So you say do it 10 times. So you count 1, 2, 3, 4, 5, 6, up to 10. So towards the end, that is when you now begin to see a smaller amplitude. So that indicates that there is bradykinesia. And that's a score of 1. A score of 2, any of the following. 3 to 5 interruptions. So in the earlier one, even 1 interruption within the 10 taps, in as much as there is an interruption, an arrest, but in 2, it's not just 1 or 2. You have 3 to 5 interruptions during the time. So it starts to tap, and then it's arrest, and then it continues, he arrest, continue, he hesitates, he continue. He does it 3 to 5 times. There is mild slowing. So earlier it was slight slowing. So it's just, you have to use your common sense to see the difference between slight, mild, and severe, or moderate. So the slowing is not, so it starts fast, then it slows, then it can slow down even more, mild. Then the amplitude decrements midway in the 5-tap sequence. So in 1, it is towards the end. So maybe 7th, 8th, or 10th. But this one at the 4th or 5th, we are going to have the amplitude decreasing. Then in 3, you have moderate. More than 5, moderate slowing. And amplitude reduces starting at the 1st tap. So right from the beginning, the patient cannot cover full range. So right from the beginning, it is this. And that is a score of 3. A score of 4 cannot or can only barely perform the task. They can't even do the task, but they can barely open. And therefore, everything is severe. So that is the finger tapping. And as I've said, this shows bradykinesia. Then hand movements. So you open and close. So can you do that? You open and close very fast. So let's also see the complete opening and then the fastness. I'll show you how Parkinson disease. Yes. So the scoring is the same. The scoring is the same. Just like you do the tapping, the scoring is the same, opening and closing. Opening and closing. So you give the same score, looking at the arrest or hesitation, looking at the slowness in movement, and looking at the amplitude of the movement. The score is the same as the finger tap. The only difference is those that the task now, instead of just the finger, you are closing and opening the whole hand. Then we have pronation, supination movement. The same scoring, but also different tasks. So what you need to do is your palm, you tap it and like this, up and down, up and down. Yes, so you do it as fast as you can. Yes, so 10 times. And when you do it 10 times, the same scoring as the earlier assessments. That's the finger tap, full hand opening and closing, and then pronation, supination, you give the same as scoring. I can see a hand up. Are you trying to comment or ask a question, or is it just the earlier comment that I said if everything is okay?
It is to ask a question. Good morning, sir.
Right.
Hello?
Go ahead, we can hear you. Go ahead.
Okay, well, I don't know whether I missed the part. The area of the hand tapping.
Yes.
The hand, yeah. I kind of practicalized it myself, and I realized that I was getting tired, like, as I carried it on consistently. So I wanted to ask, like, is there like a specified period of time these patients have to do it? Because even me as a normal human person, that I don't have Parkinson's disease. Like,
I was working with him now. I said, "Are you sure you don't have Parkinson's disease?" It is 10 times.
Not keep it on for like up to 30 seconds without interrupting or me getting the amplitude will definitely reduce. So I'm saying if you want to use this to assess patients' functionality, like, could there be a stipulated number of seconds they have to do it for? We have to monitor the hand movement for
10 times. You know,
10 what?
because of time, I don't read the whole instruction. If you go back, you are going to see instruction. It's just because I've used it. I understand the instructions, that I'm just explaining it. I'm not reading it out. If you look at the instruction, it said, and then to turn the palm up and down alternatively 10 times as fast and as fully as possible. So it's just 10 times. That's number one. Number two, if you know what it looks like in a normal individual, and that is why it's important for you to try it yourself, ask some people to do it, so that you'll be able to see, even in patients that don't have Parkinson's disease, at what point is it that you begin to have the slowing down? What is normal in the slowing down? Then you'll now be able to understand what is abnormal in a patient that has Parkinson's disease. There are so many, and I will give you an example. In mini mental state examination for the assessment of cognition, the score is 30, but the normal is 24. I think in some studies they say 23 or 24. So why will you have a maximum score of 30 and you still say when someone scores 24, he is normal? Because even in normal individuals, an item there that says phone, pen, chair, say them, then you now come and tell the person, subtract 7 from 100, subtract 7 from the answer, and you do it 5 times. Someone like me, before you come back and ask me, do you remember those 3 things? I would have forgotten. But I don't have any cognitive impairment. Many people will miss some of those things, but they don't have cognitive impairment. So you need to understand what is normal in people, and so that when you come to assess and give scoring for patients, you'll be able to know, even if they have the slowing before it gets to the 10th, it's still, and that is why they didn't give a particular number in 10, that they will say when it gets there, you begin to see the slowing. They said it is abnormal. They just say slight slowing. moderate slowing, and things like that. So it's up to you to know what is normal in a patient that doesn't have Parkinson's. So that if you see someone with Parkinson's disease, what then would be a normal or abnormal? Yes, but 10 is what is there in the instruction.
Thank you, sir.
Is that all right? Clear?
That's right. That's very clear.
Okay.
Thank you.
Thank you. Thank you very much. So that's pronation and supination. Then toe tapping. Now, what we just did was for the upper limb. Remember, with rigidity, we assess both the upper limb and the lower limb. Now, with the bradykinesia, you also assess both the upper limb and the lower limb. With the lower limb, what you do, yes. Around to show the foot is not, no, not around. I mean,
Understand.
Yes. So the ankle or the heel is on the floor. It taps the toes while the the heel is still on the floor. So can we do that? So that is the toe tapping. I hope they can see that.
Yeah.
Then another one, before we go to the scoring, because it's the same scoring, just different tasks, just like we did with the upper limb, is the heel. So don't go and enjoy your heel. Good. So as fast as you can. Good. Okay. So let's look at the scoring. It's very similar scoring or the same. I think it's even the same scoring. Looking at the amplitude. So how much high do you lift the knee up or the heel from the ground? How far do you lift it? And if you are looking at the toe tapping, how far do you lift the toes from the floor before you tap them on the ground? Then the speed, how fast do you do the activity? And then the arrest. When you start, it stops, and then you continue. It stops, and then you continue. The same thing with this. It arrests, you hesitate, and then the patient continues. So the scoring is the same. And unless if you want me to go over it again, but the scoring is the same. So there is no problem. While in slide, remember A is about the arrest, the hesitations. So just 1 or 2 arrests. Slide slowing, I've explained this. That's why they didn't say at the 5th or the 6th, because even normal people can have that slowing because of fatigue or whatever reason. And then for the amplitude, it decreases at the end of the 10 taps. While for 2, which is mild, instead of 1 to 2 interruptions, you now have 3 to 5. That is mild. While for the slowing, instead of slight slowing, it is mild slowing. And then for the amplitude, it is midway. It was at the end in 1, but in 2, it's midway that it begins to show the slowing. Then in 3, more than 5 interruptions. So instead of 3 to 5 in 2, this one is more than 5 interruptions during the tapping movement, or at least 1 longer arrest. So meaning 1, but it stays for a long time before it continues. Then moderate slowing, instead of mild, this one is slight, this one is mild, this one is moderate. Then the amplitude decrements after the first tap. So the moment you tap the first one, the amplitude reduces. And then 4 cannot, or only barely, able to perform the taps. So that's toe tapping. So this is leg agility. We have done that. So toe tapping, leg agility is the one that you do with the heel. You keep tapping the heel on the floor. Then arising from chair. So what you do is to ask the patient to do this. So the patient is going to do this. And they are going to stand up from the chair. Now, because it's a patient, it's possible they will do this, come back. They will do this, they will come back. We read the instruction, but because of time, I don't want to go through the whole instruction. So they will do this, they will come back. If at the end they can't do that, then you can allow them to use their hand and be right. So just try. We know it's going to be 0, but just try. Just stand normally, normal stand. Yes. So if they can't stand like that normally, sit down. Then you can ask them to lean forward. No, hold like this. Then lean forward and stand. Stand. Sit. Then use your hand. So that's if they can't do that. Then use your hand and stand. When you stand up fully, yes, then sit down. So let's see the score so that we'll be able to, maybe as we discuss the scoring, we can demonstrate for each score. So 0, so the scoring, no problems, able to arise quickly without hesitation. So there is no hesitation. It doesn't try and go back. Try, can't, and go back. No hesitations. Once, it does it. Give a score of 1. Arising is slower than normal, or may need more than 1 attempt. So that is where it does this, can't, then goes back. Tries and go back. So he needs more than 1 attempt, but he can be able to stand without support. That's a score of 1. And he doesn't need to hold on the chair. Doesn't need to hold on the chair. Support the hands on the chair before rising. Then 2, pushes self up from the arms of the chair without difficulty. So they use this, a stand, and that is a score of 2. So they can't do it like this. They can't do it like that. They have to support and stand, but they can be able to support and stand. That's a score of 2. 3, needs to push off, but tends to fall back. Or may have to try more than 1 time using the arms of the chair, but can get up. So even with the hand, try, goes back. Try, goes back. Then maybe at the end, stand. That's 3. 4 is unable to arise without. So someone has to hold for the patient to be able to rise. So that is for arising from chair. So you can see that one also does not have more than 1 box. It's because this is just one activity that you do. So in gait, you ask the patient to walk about 10 meters. That's about 30 feet. As the patient walks towards the other end and then turn around and come towards you. What you do is to observe the gait, and you know the normal gait pattern. They show heel strike, toe off, the space between the 2 feet, and the distance that you place the heel strike above, in front of the toe off of the other side. That distance, the distance between the 2 feet, all those terminologies, you look at them, you observe them, and then you'll be able to see if there is an abnormal gait pattern or there is no abnormal gait pattern. So the ability to walk, whether there is an abnormal gait pattern or not, these are the things that you look at to be able to do that system. So I'm not going to ask him to walk because it's not going to be a normal walk for everyone. But what is important is to know that you will have a 10-meter mark. You start from this point, go to 10 meter, turn around, come towards you, and then you now look at the gait. So very important, you look at the gait. So stride amplitude, stride speed, so the speed. Height of the foot lift, toe. So when they do toe off, how much high from the ground do they lift the toe? Heel strike, whether they put the heel down or is the whole foot that they put down during walking. When they turn around, do they turn around normally? Is there any freezing when they are trying to turn around? They just get stuck on the floor. Then is there any arm swing? Because some will just have their arms by the side. They won't swing their arms. So assess also for freezing of gait. The next item will be on freezing of gait. So what do we have? No problems, 0. They walk there, they come back. All those parameters of gait are normal, and they can be able to turn around without freezing. They come back to where you are. You give a score of 0. You give a score of 1, independent walking. They don't need support of a walking stick or aid. They don't need anyone beside them. They can walk on their own, but they have minor gait impairment. Maybe the distance between the 2 feet. Maybe they take only a small step. Instead of putting the foot that is advancing ahead of the foot that is on stance, they just put it halfway. So meaning the gait parameters are abnormal, but it is a minor thing. So it's a minor gait impairment. 2 is when you have independent walking, but with substantial gait impairment. So you don't just have this, you have this, you have a number of other parameters that we have mentioned, the strides, the speed, the distances between the foot, the distance between this foot ahead of the other foot, the number of gait parameters that are missing is substantial. You give a score of 2. 3 requires an assistive device for safe walking. They can't walk without assistive device. We give a score of 3. They give a score of 4 if the patient cannot even walk, or they need someone to hold them for them to be able to walk. So that is for gait. Then freezing of gait. Remember I said freezing of gait is about getting stuck. They can't even lift and move. The body is trying to move, but the foot gets stuck on the ground. So when they walk, so you can assess the freezing of gait while they are doing that 10-meter walk. So while they are walking, because they are going to turn around. Another thing is if there is a door that they pass through, that also will help for us to be able to know if the freezing of gait will come when they are passing through a door, because I told you, during turning or passing through a door or an obstacle, usually they get the freezing there. So if there is no freezing, we give a score of 0. They freeze on starting. So some Parkinson's disease patients is when they are starting the walk that they freeze. Some when they are turning, or when they are walking through a doorway. But when they are walking smoothly, straight walking, there is no freezing. We give a score of 1. 2 is when they freeze on starting, turning, or walking through the doorway with more than 1 thought. So with 1, there is freezing, but it's just once. They freeze and they continue. But with 2, it is in those circumstances of starting, turning, or door, but the freezing is more than once. They freeze, they continue, and they freeze again. With 3, freezes once during straight walking. So in 1 and 2, in straight walking, no freezing. But in 3, with straight walking, there is freezing, but only once. While in 4, is straight walking, but more than once. I hope it's not confusing. Just let me know if it's confusing so that I will come again. Okay, any response? Is it clear? Or do we need to look at it? I hope I'm not muted. I need feedback. If not, I'll think the network is gone, that I'm just speaking to myself. Okay, good. Okay, someone says recover. Okay, so we are looking at 2 things now. Number 1, straight walking. Okay, let's now. Anyway, I don't know, maybe you can use it. So let's assume this is a 10-meter walk test. You can stand from there. I will stand there. No, you can stand from there and face this side. You can come forward so that they will see you in the okay. So I want you to walk. Okay, I want you to stand there because I want to go forward. So I want you to walk towards the door, towards the end, and then come back. Now, you understood the things that I was explaining. You get stuck on the floor. You can't start. And then you start to walk. And then at some point, you get stuck. You understand? So remember the stories. Number 1 is when you start, when you get to the door, when you are turning around. I just want you to assume that you get stuck as you move. So when you are going, you only freeze when you start, when you get to the door, and when you are. But when you are coming back, even while you are walking straight, you freeze. Yes. So just walk. No, walk normally. So you're freezing, you don't stop. That's straight walking. So this is straight walking. As he's walking straight, he freezes. That is what it means 3. While in 4, he freezes more than 1 while he's walking straight. That's the walking straight that they're talking about. So walk straight. Walk straight. Come towards him. So this is walking straight. So when someone is walking straight, as you are walking straight, freezes. Come move. Then he now begins to move. And then he freezes again. He can't move. So that is 3 and 4. But in 1, that is where right from the time he now begins to move, he freezes. But when he's walking straight, no freezing. But when he's turning around, he then freezes. He freezes as he's turning around and then releases and now continue to move. I sit down. So that's why we said 10-meter walk. So walk 10 meters. And while you are walking, if you are walking straight, you are not turning around. You freeze. It is 3. If you freeze more than once while walking straight, not turning around, it's 4. But when you freeze, when you start only, or when you are turning around, or when you are going through a door, it's only when you are starting, when you are turning around, or when you are going through a door that the patient freezes, you give a score of 1. So freezing on starting, turning, or walking through doorway. But with a single freeze is 1. With more than 1 freeze, only at start, turning, or at a door, but more than 1 freeze is a score of 2. Freeze while walking straight. So you are not turning. You are not going through a door. You are just walking straight. You freeze once. That's 3. You freeze more than once while you are walking straight. It's a score of 4. Then postural stability. There's also a lot of information I'm not going to read out, but I'm just going to demonstrate. So you are going to stand and face the other side. So you stand and face the other side. Now you explain to the patient. I think maybe can you come towards this side? Let's see if it will be better. Yes. So you explain to the patient, I'm going to pull you back, and it's all right to take a step or 2 to regain your balance. That is a normal thing. It is all right to take a step or 2 back to regain your balance. So we'll look at the scope, but let's just do it this. So it's okay to tell the patient that you're going to pull down. Some people would say, let me just take the patient unawares. No, you can tell the patient, I'm going to pull you, and it's all right to take. So you're going to pull with force that will make the patient to move back, take a step before they regain their balance. So you're going to pull. Okay. So you only took a step, and it's okay to take 2 steps. So you hold and you pull. So he took 2 steps in this. In the first one, he took a step. In this one, he took 2 steps. So half a step, 2.5. But at least it's 1 or 2 steps. It's okay. It depends all on the amount of force that is used to pull the patient back. So when the patient recovers with 1 or 2 steps, it's normal. But when they recover using 3 to 5 steps, but subject recovers unaided, you don't need to support them, you don't need to hold them. but they use more than 2 steps, 3 to 5 steps, then it is a score of 1. A score of 2, more than 5 steps, but subject recovers unaided. Then moderate, stands safely, but with absence of postural response, falls if not caught. So even if you don't pull them, they are about to fall, you have to hold them. Very unstable, tends to lose balance spontaneously with just a gentle pull, and the shoulders fall. So this is the pull test for postural stability. Then posture. When the patient stands, is just looking at the posture. Not quite erect, but posture could be normal for other persons. They stoop a little bit. So it will be that. We give a score of 1. There is definite flexion. So either they have flexion or they have scoliosis or leaning to one side. They lean to one side. May not be scoliosis, but they are leaning towards one side. It's a score of 2. The patient can correct the posture. So if you say you are leaning forward or you are leaning towards the side and you move, the patient can correct it. That is a score of 2. Score of 3, stoop posture, scoliosis or leaning to one side that cannot be corrected volitionally to a normal posture by the patient. That is 3. While 4 is flexion, scoliosis or leaning with extreme abnormality of posture. So meaning in 3, you have slight abnormality. It can be corrected, while in 4, it is severe. The curvature is severe and it cannot be corrected. That is the posture. So there are many other things, but because there are other outcome measures, and I can see we have just about 1 hour, I may not go through all of them. Maybe I'll just quickly explain that. So global spontaneity of movement. So just sit down there, let me go back. If I need you, I will come. So this is an observation by the examiner. The examiner makes observations and a report. So it's looking at general body slowness. So general body slowness. Say there is no general body slowness, slight global slowness, and poverty of spontaneous movements. So this is a global thing. As you have been doing all these examinations, you are observing the patient, and you now want to give a score for the total body slowness and movement. Then postural tremor of the hands. So this tremor, I think we looked at bradykinesia, we looked at rigidity, we looked at abnormal posture. Now we want to look at the tremor. So possibly this is something that we may not need to do with but let's see if it requires a subject. So you are observing the hands or the legs to see if there is any tremor. So that is present. The posture is to be included in this. To rate each hand separately. So you rate that. That is why here you have right and left. So it's the hand. So is there any tremor? Tremor is present for less than 1 cm in amplitude. So there's tremor, but less than 1 centimeter. The patient, you see the movement, but it's less than 1 centimeter. Mild, there is tremor, is at least 1, but less than 3 cm. So it is more. The amplitude is more. You see this movement in the patient. It is more than 1 cm, but it is less than 3 centimeter. Moderate is more than 3 cm, but less than 10 cm. So it's not up to 10 centimeter. While in severe, you see, in some patients, you see them as if like this. They just keep flapping. So that's a score of 4. And this is the postural tremor of the hands. Then kinetic tremor. So maybe we can come here so that I don't have to turn around again with the system. No, you can sit. Just face me and sit. Move it. Okay. So turn and face me. So what I want you to do, you will touch my finger. You will touch my finger with your finger, and then you will touch your nose. So touch my finger, touch your nose. Yes, slowly touch your, no, with the same hand. Touch your nose. Aha, touch my finger. Good. Slowly, not fast. We are not looking at the speed now, like the other test. Just touch slowly. Touch my finger, touch your nose. So then observe the tremor. So in some patients, when you just observe the hand at rest, you may not see the tremor. But by the time they are doing this activity, you may observe the tremor. So, and you give the same scoring about the issue of, okay, let's do this. So don't do it. So touch. So if you do it very fast, you may not see the tremor. And you are not really after the patient being able to touch, because that will now be a test for the cerebellum to see if there is coordination of movement. That's not what we are looking for. All we are looking for is not the accuracy of whether they touch the nose or they touch the finger. We are only looking at the tremor as they are moving. So that's so that's the kinetic tremor of the heart. So no tremor is present, but less than 1 cm in amplitude. I think that's the same scoring as the one for the resting tremor. The resting tremor, they call it postural tremor of the hands. This one is action tremor or kinetic tremor of the hands. Rest tremor amplitude. So then this is the rest tremor amplitude. This and the next item have been placed purposely at the end of the examination to allow the rater to gather observations of rest tremor that may appear at any time during the exam. So this just of the patient is resting, no tremor, less than 1 cm in maximal amplitude, 1 cm to 3 to 10, and then over 10, similar to that also. But in this, you are also assessing the jaw. So usually they can have the tremor in the jaw. So you also test it. But instead of up to 10 cm, the maximum for the jaw or the lip is 3 cm. The tremor is it at a later stage than the resting tremor, which comes first. The resting comes first. The postural. So let's see, go back and read the instruction examiner, all tremor, including reemergent, that is present in the posture, in this posture, is to be included in this rating. Rate each hand. Instruct the patient to stretch the arms. Sorry, that's the difference. That's the difference. I think I missed it. I just remembered. This is when you ask the patient to put their hand up there. That's the postural tremor. So apology. The postural tremor is like this. So you ask the patient to put their arms up there, and then you observe the tremor. So that's the postural tremor. When you do that, then you now do this kinetic one. And then the third one, you just ask the patient to sit with their hands possibly on their laps, and you just observe the rest tremor. So sorry, apology for the confusion. The first one, postural tremor, put your hands up there. The second one, do the movement. That's the kinetic. Then the third one, rest. So this kinetic, then rest tremor. So as I've said earlier, they increased it. In the one that I used some years back, there were many items that are not here. But since it has been updated and it has been shown to be valid and reliable, I thought instead of using the simple one, that we should use this one, the one that is updated. Is the kinetic tremor the same as intention tremor? Yes. So that's the one that you do while moving. Yes. Usually they just use different terminologies. Then constancy of rest tremor. So whatever you have seen earlier, you are looking at it. Is it there most of the time, or just halfway, or just 1/4? So lastly, before we look at the Hoehn and Yahr stage, which summarizes everything, we are going to look at whether there is dyskinesias or chorea or dystonia. The difference between chorea and dystonia and tremor. In tremor, it is predictable. So they are all abnormal movements. But tremor is predictable because when you have a tremor, you have something like this. So it's predictable. You know, it's going to go up and down, and maybe even the speed can be predicted and the amplitude and what have you. But with chorea, it's not predictable. So you can start like this and move this way and move that way. So you see the patient just twisting. It keeps moving from one to another. So you find out, is there any chorea? With dystonia, you see the abnormal movement, but you have the agonist and the antagonist. There's co-contraction in the agonist and the antagonist. And that limits the amplitude to which the abnormal movement is seen. That is dystonia. While with chorea, so it's unpredictable, not like tremor. It can go to any side. While with tremor, usually it's predictable because it has a predictable pattern that moves only that is abnormal and continues. So you ask if you observe if there is any chorea or dystonia, either a no or a yes. And if yes, these movements interfere with your ratings so that you'll be able to know if your ratings as a result of the Parkinson disease or there is any interference with other abnormal movements such as chorea or dystonia. So finally, Hoehn and Yahr stage. After doing all this motor assessments, examination that we have just done, we now come and say, is there any symptom? Any bradykinesia, any rigidity, any abnormal posture, and any tremor? So if there is any, maybe in one joint, only one of those cardinal symptoms that has been seen is not asymptomatic. But if there is no, then it's asymptomatic. Then score of 1, unilateral involvement only. Okay, can we someone mute Jennifer? Or should I reclaim and mute? Oh. Abimbola, is it that earlier time that you raised hand, or is it now? I've put down the hand. If it is a new one, you can raise again. Yes, so number 1 is unilateral involvement. So maybe you saw the tremor in only this hand, but not the left side. Or maybe there's rigidity in this side and not the other side. Or maybe there is bradykinesia in this side and not the other side. Whatever it is that you see is on one side, is not on the other side, and there is no postural problems, no impairment of balance. So that is 1. 2 is when there is bilateral involvement. So you see tremor on this side, tremor on this side, or you see rigidity on this side and rigidity on this side. It's both sides that you have the symptoms, but there is no postural imbalance. So when they are standing up, that item, the score is 0. When they stand and you pull them, they take only 1 or 2 steps and that's it. So no impairment of balance, you give a score of 2. A score of 3, when there is mild to moderate involvement. So meaning the scoring is not 0 or 1. It is not also 4. It might be 2, around, that's moderate. So when you have 1 or 2, mild to moderate involvement, there is some postural instability, but physically independent. The patient does not need support to do things. They need assistance to recover from pull test, but they can do physical activities independently. And the problem they have with the symptoms is mild or moderate. So you give a score of 3. You have severe disability, but still able to walk or stand unassisted. That's 4. And then 5 is wheelchair bound or bedridden. So they are wheelchair bound or they are bedridden. We give a score of 5. So that's the Hoehn and Yahr stage. This is what summarizes the whole of what we did, and it gives 1 score for the patient. So meaning the patient can improve, but they may not move from 2 to 3 until at a later stage. But if you want to know, no matter how little the improvement the patient has gotten after treatment, or how worse they have become, because how worse have they become, since it's expected to become worse, but how worse have they become? Then you now have to go back and do the UPDRS complete, and then you'll have the score. And as I've said, there are many other sections. Because of time, I'm not going to go through them, but I picked the ones that I know are more difficult to assess, that may need some practical sessions. But at the end of the day, you are going to have a score sheet. The scorings that you have there, you will now come here and enter them. So you enter them, and at the end, this is what is going to give you what the patient's situation is. So if you go up, you are going to see other sections. Like I said, we discussed the issue of depression, so cognitive impairment, hallucinations and psychosis, depressed mood, anxiety, apathy, and other sections. But all of them, they are self-explanatory. The patient questionnaire, this is the one that you ask the patient questions and or the relative, they give you answers. So you enter whether it's the patient that gave you the information or the caregiver or the patient and caregiver. Then you have non-motor aspects of experience like sleep problems, daytime sleepiness, pain and other sensations. These are all straightforward things, urinary problems, constipation problems. This UPDRS is a comprehensive assessment for patients that have Parkinson's disease. Part 2, because motor that we did is part 3. This is motor aspects of experiences of daily living. So they're asking how speech affects your interaction, your activities of daily living, saliva and drooling, chewing and swallowing, eating tasks, dressing, hygiene, handwriting, hobbies, turning in bed, tremor. So that tremor is about how the tremor affects your activities of daily living. Getting out of bed, a car, or a deep chair, walking and balance. The freezing is how it affects activities of daily living. It's not at level of impairment like the other one. So this is the motor examination, the one that we did. So this now completes the UPDRS. Now I took time on it, took us almost 1 hour, I think, but I think it's worth it because it's the primary thing that gives you information about the cardinal signs and other non-motor signs and other symptoms that comes with UPDRS. It's a holistic approach to the assessment of the Parkinson's disease. So if there are any questions or concerns with what we have just done, let's discuss that before we get to the next outcome. Oh, the sharing was even post. I hope as I was scrolling and talking, you were able to see what I was doing. Okay, any concerns, any comments? So no comments. Should we go to the next outcome measure? All right. So let's take the mini bests. This is for balance, or maybe we start with freezing of gait. These are simpler ones. Let's start with freezing of gait before we go to the mini best. That is for balance patients that have Parkinson's disease. So let's start with freezing of gait because we have discussed freezing of gait, and it's a simple assessment. So it's very important to assess freezing of gait in patients that have Parkinson's disease because it's something that really affects many and it stops them from activities that will affect their activities of the living. So it's simple. During your worst state, do you walk? As the patient, during your worst state. So this worst state could mean they are off levodopa. So that's when they usually have their worst state. So do they walk? It could be any other reason why they have a worse state. So say normally, almost normally, somewhat slow but fully independent, need assistance or walking aid. So I think this Likert scale is the straightforward thing. But the questions, number 2, are your gait difficulties affecting your daily activities and independence? Do you feel that your feet get glued to the floor while walking, making a turn, or when trying to initiate walking? This is the freezing. So this freezing, very important. How long is your longest freezing episode? So how long does it last when you freeze? Never happened. 1 to 2 seconds. So you freeze for 1 to 2 seconds, a score of 1. You freeze for 3 to 10 seconds, a score of 2. Then 11 to 30 seconds, a score of 3. Unable to walk for more than 30 seconds, a score of 4. How long is your typical start hesitation? Remember, when we did that assessment, we said the patient can have freezing when they are starting to move. So they just talk, they can't move until later. So how long is your typical start hesitation episode? Freezing when initiating the first step. So that also none takes longer than 1 second, like what we had earlier. How long is your typical toning hesitation? So this is freezing when toning. The earlier one was freezing when starting the movement. So this is it. It's simple, scoring from 0 to 24. Higher score denotes more severe freezing of gait because number 4 is always the most severe. So the total 24, if you score 4 in each, you have 24. It means you have severe freezing of gait. And this is minimally detectable change. I think this is a statistical thing that shows clinically if it's really significant to show a problem. Not established in increased sensitivity on question 3. So, but this is it. That's the freezing of gait. So I'm going to send you all these outcome measures on the platform. Then let's look at fear of fall. Falls risk assessment tool, FRAT, falls risk assessment. Very important to assess this in patients that have Parkinson's disease because they are prone to falls. It's very, very important to assess. So I'll just keep the first part, introduction, you can read that, but this is what it is. So recent falls. So it's looking at the risk factors and then gives a score, and then it will give you a total score. So recent falls, have they had any recent falls? To score this complete history of falls or value. So there is a history of fall that is attached to this. So you complete that. And then at the end, you'll be able to know the levels. So have they had any falls in the last 12 months? If none, we give a score of 2. 1 or more between 3 and 12 months ago, we give a score of 4. 1 or more falls in the last 3 months, 6. 1 or more in the last 3 months, whilst inpatient/resident. So while they were inpatient, they had more than one or more falls in the last 3 months, they gave a score of 8. Then medications. Are they on any sedatives, antidepressants? Because we are looking at risk factors, things that can make them to fall. It doesn't really have to be just the Parkinson's disease itself. It could be as a result of medication. Antiparkinsons, diuretics, antihypertensives, hypnotics. So any of them. Not taking any of this, score of 1. Taking only 1 out of them, score of 2. Taking 2, taking more than 2, score of 4. Then psychological. Do they have any anxiety, any depression, any decreased cooperation, any decreased insight? So insight is when you have, because we didn't go through those hallucinations and what have you in the UPDRS. I jumped them because of time. But insight is when you have hallucinations, or yes, you have hallucinations, you see things that are not there. But when you are giving evidence that those things are not there, you agree that they are not there. So that's insight. So when there is no insight, you just see a small girl coming with a knife towards you. And people tell you there is no one. In fact, someone even goes there where you point at the child and they wave around to show you that nothing is there, but you still don't believe. You say, it's there, it's there. So there is no insight. So these are psychological problems. So when you have hallucinations with decreased insight or judgment, especially ability, so all these things put together. So it does not appear to have any of this, appears mildly affected by one or more of them, appears moderately affected by one or more of them, appears severely as affected. So you give a score of 1 to 4 for that. Then cognitive status. So there is this assessment, MTS, the Parkinson abbreviated mental state test score. So we need to get that and study it because I don't have it here. But the scoring you have in that will now determine what scoring you have here. And finally, you have a score of 20 total. So whatever the patient scores, you can be able to know that they are at low risk, whether they are at medium risk or high risk of falls. So 5 to 11 shows low risk, 12 to 15 over 20, medium, while 16 to 20 is high risk. So these are some of the risk factors, and it's important to take note of these ones. Vision, mobility, transverse behaviors, observed or reported agitation, confusion, disorientation, activities of daily living, observed risk-taking behaviors or reported from the referrer, observed unsafe use of equipment, unsafe footwear. So these are something that you take note of, because there are things that you will now reverse for the patient's fall risk to be reduced. So that's it. Here's the action plan. What will you take? If you have a problem with footwear, what will you do? If you have a problem with taking medication, what do you do? If you have a problem with psychological problems, psychosis, hallucinations, what do you do? Maybe you refer to a psychiatrist, psychologist, or whatever. So very important to be able to reduce the risk of falls, because it has been shown to lead into a lot of health challenges, fractures in the hips, and many other things because of falls that the patients will have. So that's the falls risk. Well, I think it's still not up to 12. I don't know if you need a 5 minutes rest. It's just too much bombardment. Do you need rest, or should we continue? Yes, that's what I said. I said I don't have it here. So maybe you get it and you study it. I think it was about cognition, isn't it? The one that we did was mini mental state examination and Montreal cognitive assessment. So I don't have that here, but before we leave, I will search for it and I will share it. I will search and share it. I'll show you. Okay, so no one is saying we should take a break, so maybe we'll just quickly go to the next one. So there are, remember, whenever you are assessing patients, don't just assess them at the level of impairment. The UPDRS that we saw activities of daily living. So at the level of activity, there's assessment, but there is also participation, which is very important. So sometimes because of time, we are not able to go through all, but you should be able to take note of that. So let's see the mini best assessment for balance. Okay, so this is the mini best test for balance. Let me share it. So this one, we need to do some practical. Okay, the last slide. Can you let me know which one that? Which one are you talking about? Is it the, okay, that's the risk of fall. Is that the risk of fall? Just confirm. Are we having audio challenge? Someone is asking whether there is audio challenge. Is it from me or is it from the person? Okay, yes, sir. Okay, so let's open that and do that before we go to the mini best. Audio is good. Okay. So Mr. Emmanuel, Sonny Emmanuel, I think it might be from you. So I think the one we did was frat. Usually when there are many things to do, I rush things. And that's why I keep asking if anyone has any issues so that we go back. Yes. So, okay. Okay, so the falls risk assessment assesses the risk of fall. How much of risk has someone to fall? So recent falls, we said, you ask the patient, have they had any fall recently? So in the last 12 months, how many falls have they had? In the last, between 3 to 12 months ago, how many falls have they had? In the last 3 months, how many falls have they had? And that is what is going to help you to be able to give a score of 2 to 8. Then the medications they take, you also use that to do the scoring. So whether they are sedatives, antidepressants, and what have you. Then the psychological problems that they have, that also will form a risk, and there's a scoring for that. Then cognitive status, that's what I said. I don't have the tool here for the Parkinson Abbreviated Mental Test Score, the AMTS, but I will share it. So when you use that assessment tool, it has scoring. So the scoring that it has is what you are going to use to now give a scoring on this frat. So at the end of these ones that we have assessed, then you'll be able to know the total. And then from the total, you'll know whether the patient is at low risk of fall, medium risk of fall, or high risk of fall. So these ones are the risk factor checklist. So you are looking at what risk factors the patient has. And that's when you look. I was just in a hurry that I passed through it because I thought there are straightforward things. For vision, you are asking if there are any reports that the patient has visual problem, observed difficulty seeing objects, signs, finding way around. So you ask about these things. So you know if there is any mobility issues, apart from mobility issues, if they have any behavioral problems, agitation, confusion, disorientation. So it's a yes or no on this. So these ones you have scoring, but on these ones is a yes or no. And then you have activities of daily living. If they have any observed unsafe use of equipment, so they have any equipment that they use but not safely. If they have a footwear that is unsafe, so you can't have Parkinson's disease and you now want to begin to use high heel shoe, especially when you have freezing. Or when you begin to have the fascination. So the body is moving forward. The foot is not moving as fast, and you're still wearing a high heel shoe. Then the environment, difficulties with orientation to environment, areas between bed, bathroom. So are there any obstacles in the environment that could predispose the patient to falls? Is the patient underweight? Continence, are they incontinent? And then is there any other thing that is a risk factor? So you fill it in with yes or no. Then at the end of the day, you now come and you have an action plan. From all these risk factors that you have, the ones that are scored over 20 and the ones that are just yes or no, then you now use this action plan. So anyone that you have scored low, or you said you have yes here, because there's a problem, you have yes here. You now pick them, you put them in this problem list, and then you provide intervention strategies or referrals. That's why I was telling you earlier. If, for example, they are malnourished, then you refer them to a nutritionist. If they have, what is it that will require referral again? Nutrition continence. It's possible if it is an organic pathology, you refer to a urologist or whoever it is. They have behavioral problem, confusion, agitation, you refer to a psychologist. But the issue of mobility, transfers, you keep them, you see them, but you state what you do for them. Then for vision, it's possible you refer to either an ophthalmologist or an optometrist. So this is what this tool is about. This is an action plan. What do you do when you identify a risk for fall? So you are now treating it or referring for it to be treated so that you can be able to solve the problem the patient will not be falling. So I hope this is clear. So very quickly, let me share the mini best. Okay, wonderful, thank you. Okay, we use the PRAT for all our geriatric patients. Yeah, it's just any outcome measure you use, you check if it is valid and reliable for use in that population. And that's Ryan Shally that I sent to you, rehabilitation measures database, usually gives that information about psychometric properties across populations. In as much as it is valid and reliable for use, then that's very okay to use. Yes, so we have the mini best. It's a balanced evaluation system test. So number one is sit to stand. Sit to stand. So cross your arms across your chest. This is similar to the one we did in the UPDRS. So cross your arms across your chest. Try not to use your hands unless you must. You will not let your legs lean against the back of the chair when you stand. Please stand up now. So you give a score of 2, normal, comes to stand without use of hands and stabilizes independently. 1 is moderate, comes to stand with use of hands on first attempt. 0, severe, unable to stand up from chair without assistance. Will need several attempts with use of hands. So you can see the scoring is you can see the scoring is, instead of 0 to 4, here is 0 to 2, but the instructions is the same. And I think we have done that earlier. Then rise to toes. So you understand the instructions because I'm going to ask you to do it. Rise to toes. Place your feet together, width apart. Place your hands on your hips. So you're going to place your hands on your hips. Try to rise as high as you can onto your toes. So onto your toes, exactly. I will count out loud to 3 seconds. Try to hold this pose for at least 3 seconds. Look straight ahead. Then I'm going to tell you, rise now. So, okay, maybe you will help us. I'll say right now, I will count 3. Stand, and then when I say rise now, you now rise on your toes. And I will count 3 seconds. So rise, rise. 1, 2, 3. Sit down. So this is second item, rise to toes. So you score normal is score of 2, stable for 3 seconds with maximum height. So he does not bend, he's straight, and he was able to do it for 3 seconds. So that's normal. Moderate, heels up, but not full range. So the heels are up, but it's not full range, but smaller than when holding hands, or not noticeable instability. So it's not full range. Then 0 is severe, less than 3 seconds. So for 2, he's able to do it 3 seconds, but not full range. While in 0, it's not just about full range, he's not even able to do it for 3 seconds. Then the third one is when you stand on one leg. So I'm going to give the instructions, and then you are going to do it. So look straight ahead. Keep your hands on your hips, just like the other one. Lift your leg off of the ground before you without touching or resting your raised leg upon your other standing leg. Stay standing on one leg as long as you can. Look straight ahead. Then we'll say lift now. So the normal is 20 seconds, and therefore we are going to do 20. So you are going to stand, lift one leg. Yes, but let's. Well, these are all simple cases, but it's good because I remember someone asking, what does it mean stretch walking? So sometimes we just assume things, but when we do them practically, then people see them and they remember. So I want you to lift one leg and stand 20 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. So you can do 2 trials. So you do the left and then you do the right. So the left foot, right foot. So normal 20 seconds, moderate less than 20 seconds, severe unable to even stand and lift the leg. So to score each side separately. Use the trial with the longest. Then reactive postural control. So compensatory stepping correction forward. And so stand with your feet together with apart, arms at your side. So you are not holding the hip now. So arms aside, lean forward against my hands before you towards forward limits. When I let go, do whatever is necessary, including taking a step to avoid. So you stand. Okay. I'm going to put my hands around your chest. No. Just put your leg down. You put the leg down. You want us to. So that's that. So do you remember what we did earlier that I pulled you back and you take a step? So I want to do something similar, but I'm not pulling you this one. You are going to push against my hand. So you push. So I'm going to release. You can take a step. So that's one step. One step. So what you do, you place your hands against the shoulder from front. So you can pull back a little bit so that when he steps, because I put my leg very close to his, and when he stepped on my leg. And that may be what will stop him from taking another step. So you need to possibly move back a little bit so that if he's taking more than one step, you'll be able to see and you can move away, especially if he's not going to fall. Because if he's going to fall, then he's still hold up to support. So let's do that. Put your legs together. No, not too much. Yes. What it means, don't take a stance. So push, one step, and that is normal. That is normal. So the scores recovers independently with a single large step. Secondary alignment step is alarm. So if you take second, it's still okay. Moderate, more than one step used to recover equilibrium. Severe, no step, or will fall if not caught, or falls spontaneously. So this is the scoring. Then compensatory stepping correction backward. So this time around, similar, but from the back. So stand with your feet together, shoulder width. So not together, shoulder width. So your feet, shoulder width apart. Arms at your side, not on your hips. Arms at your side. Lean backwards against my hands. Lean backwards against my hands beyond your backward limits. When I let go, do whatever is necessary, including taking a step to avoid a fall. So let's do it. So it's the same thing, but we are going to turn around. Please press that side, and I'm going to hold. So put your legs together. No, not together. No, one should not go beyond the other. Yes, because I know that's why what you are doing. You want to have balance so that when I release you, you don't take a step. So the feet must be together. This one, move it a little bit forward. The width should be shoulder width apart. So you can move them, open them. So back. Good, one step. So you took one step, and that is normal. So a patient that has a problem with balance is going to may take more than 2 steps, or when you release them, they will fall. So it's also a similar scoring. Recovers independently with a single large step, more than 1 step used to recover equilibrium, severe, no step, or will fall if not held. So lateral instruction, stand with your feet together. So this is similar, but from the side. So I'm going to hold your hip side, and you're going to shift, and then I will move. So stand with your feet together, arms down at your sides, lean into my hand beyond your sideways limit. When I let go, do whatever is necessary, including taking a step to avoid. So, to the side, yes. Okay. Good, 1 step, then the other side. Your leg are hard, they are too wide. They are too wide. Okay. So, what's this side? But whichever way you took a step, so that's still okay. Yes, you wanted to do to Yes, so it's similar. Normal recovers independent with 1 step, several steps to recover equilibrium, severe falls or cannot steps. Then sensory orientation, stance, feet together, eyes open, firm surface. So you start with a firm surface. It just stands and then closes the eyes. So this is like the Romberg test. Stance, eyes, this eyes open, firm surface. So this is the first step. Usually you vary. So you can eyes open, eyes closed, eyes open on form, eyes closed on form. I think that's how the sequence is. So look straight ahead, be as stable and still as possible. Sorry, just a second, let me think. So there's a lot, I speak fast. So the scoring is also simple because it's just either 30 seconds or they can only stand for less than 30 seconds or they are unable to stand at all. Then stance, feet together, eyes closed, foam surface. So this is the next. I don't have the foam here, but if you have a foam, you use the foam, the patient gets on top of the foam, they close their eyes and they are on top of the foam, their feet are together, and you see how long they can. So you have to time them. As they stand, you stop the stopwatch, up to 30 seconds, normal. Not up 30 seconds, moderate. They can't even stand. The moment they stand, they are going to fall, you hold them, you give a score of 0. Now there is an incline. So you have a slope and the patient stands on it, meaning this is varying the proprioception in the ankle. So when you incline, the ankle proprioception is stimulated. So eyes closed and incline. So you do that and you have stands independently 30 seconds and aligns with gravity. So they align with gravity, they don't move forward because of the ankle, they may move far forward, but they are expected to stand and align with gravity. Then speed, dynamic gait. So change in gait speed. So this one, you are going to ask the patient to walk across, I think, about 30 feet or 10 meters, like we did earlier. So the instruction will be begin walking at your normal speed. When I tell you fast, walk as fast as you can. When I say slow, walk very slowly. So we are going to do that. When you start, I will say start. When I say fast, you walk fast. When I say slow, you walk slow. So just, no, let it be okay. Yes. There, you want me to move the chair? They can see. It's not you. It's that. Okay, so I'm going to say go. When I say go, you walk. When I say fast, you walk fast. When I say slow, you walk slow. Okay, go. Walk fast. Walk slow. So then you turn around and come back. Exactly. So he walks fast and then he walks slow. So you give a score of 2. It's normal, significantly changes walking speed without imbalance. So as he walks fast, okay, I can see, maybe it's another hand. Let me just explain the scoring here before we answer the question. Maybe if you want to sit because I'm inside. So significantly changes walking speed without imbalance. Moderate, unable to change walking speed for signs of imbalance. So he can't change. I saw it. I don't know if you saw it, that he was able to walk fast the moment I gave the instruction. And when I said slow, the moment I gave the instructions, he began to control the speed and he walked slowly. So severe is unable to achieve significant change in walking speed and signs of imbalance. We give a score of 0. Yes, Abimbola. Or is it the old hand?
No. I'm here. Good afternoon, sir.
Go ahead. Yes.
Yes, for the balance test, I wanted to ask, like, with feet together, do you check, does it count? I don't know how to put this. We wait for 30 seconds. Does it still hold if they sway, or it is only if their feet move apart that we count it as they can't hold on?
Okay, that's the incline, I suppose, the stance, right?
Yeah, all those stance, eyes closed, eyes open.
No, see, one thing with this test is that if it doesn't give you that instruction, then don't bother about that. Remember when we did the tremor, I was telling you, I said, if we were testing for coordination, if they can't be able to touch their nose, then there will be a different scoring. It will not be a maximum scoring. But we said it doesn't matter whether they touch or they don't touch. That's not what we are looking at. What we are looking at is whether they are able to have the tremors while they are trying to do the activity. So maybe when they touch the ear or the eyes, or they don't even get to the nose, but at least they are moving and you see the tremor. That's what we are after. So if the tests don't signify any other thing, don't consider those things. So if you look at the instruction, it's very clear. What we want to have there is step onto the phone. Place your hands on your hips. Place your feet together until almost touching. Be as stable and as still as possible. Until I say stop, I will start timing when you close your eyes. So what it's looking at is just how long you stay. Now, remember also when we're doing trunk impairment scale, we said hold your hand on your chest. Touch the bed with your elbow. Item number 1, it doesn't matter how you do it. Do you have good shortening and lengthening? Is there any compensatory activities? In as much as you touch and you come back, you have a full score there. But then the next one is when they now consider, is there good shortening and lengthening? And then number 3, it doesn't matter in number 2 whether you have compensatory things or not. Number 3. So I think this is just the rule of thumb. If it is not part of the item, don't consider it. In as much as they stand still, that, as I say, be as stable and still as possible until I say stop. But the scoring is just about the timing. Then consider the timing. Whether you see the sway or you don't see the sway, in as much as they don't fall, but they stand for 30 seconds, then it's still in order. You give a score of 2, 1, or 0 as it is.
Okay, so if I'm to understand this, like whether they sway or not, it does not matter. They put their feet together. So what if their feet move from the initial position of being kept together?
That's what I'm saying. That is what has been said here, that they need to have the foot together. If they miss it, then that is when you now have a problem. But in as much as the feet are there and they are standing, okay, he said be as stable and still as possible. So these are the conditions. In as much as you have those conditions fulfilled, then that's okay. If you don't have the conditions fulfilled, then you are going to have a score that is of 0 because you did not fulfill the conditions. So that's what I was talking about. If there is no condition, don't be bringing in condition yourself. But if the condition is there, so what is the condition here? The instruction: be as stable and still as possible. So what you are talking about can come in here. So if they sway, are they as stable as possible? No. So meaning they were not able to follow the instruction, and that is unable. I hope I'm not bringing in confusion, but the simple thing is that what is the instruction? If they can be able to follow the instruction, it's fine. Don't bring in anything outside. But what you are talking about, I can see that in the instruction. Be as stable and still as possible. So if they are swaying, are they as stable and as still as possible? They are not. So that means they are unable. So it's not just about the timing, but it's also about the instruction. So I agree with you. If they sway, they have not fulfilled the instruction of being as stable and still as possible.
Okay, now that's straight. Thank you, sir.
Okay, thank you. Yes, so I think we have gone dynamics. So we looked at change in gait speed, then work with head turns. So the instruction now. The instruction, begin walking at your normal speed, just like we did earlier. So that one, you are increasing the speed or reducing the speed. But this one, when I say right, turn your head and look to the right. When I say left, turn your head and look to the left. Try to keep yourself walking in a straight line. Yes, Abimbola, please, can you put down the hand so that I'll be able to know if you are raising it again? So I'll say go, and then when I say right, you turn right, you drop the head. When I say left, you turn left. Are you sure you are facing me? Not turn around, turn around. The other side, the other side, the other side. Good. Because as you start walking, you miss it. Okay, go. Right. Don't stop. Don't stop. You turn right and you continue walking. So go. Right. Good. Left. Right. Wonderful. So you said right and he keeps walking and he turns right. You say left, keep walking and turn left. So that's horizontal turns. So the scoring: performs head turns with no change in gait speed and good balance. So initially, you started with a change in gait speed. You stopped, but I think possibly you didn't understand the instruction. But by the time you came back and I said, continue moving. When you turned, it was seamless. I didn't observe change in speed or change in balance. Then moderate performs head turns with reduction in gait speed. So that first one you did was score of 1. But that was because so you need to give the instruction very clearly. Let the patient understand what the instruction is. Severe performs head turns with imbalance. So they as if they are going to fall when they turn. Then work with pivot turns. So this one, we are turning. So begin working at your normal speed. When I tell you to turn and stop, turn as quickly as you can, face the opposite direction and stop. After the turn, your feet should be close together. So you are going to be walking and I say turn. You turn around and you stop. No, you will not be walking. You just turn around and you stop. Ready? Okay, walk. Turn. Okay, that's it. So please, can you give us feedback? Can you see him very clearly as he does the activities? I don't know whether the lightning or the way he holds the computer, because they're using a crude method. I came with an iPad, but I thought if this one can work, it's still okay. Yes, okay. So you can see clearly. Wonderful. You can put on the other light, the light on the center. Okay. Okay, that's good. Okay. So that's then step over obstacles. Begin walking at your normal speed. When you get to the box, so there will be a box, step over it, not around it, and keep walking. So this one, I think we don't need to do that. So the normal is able to step over the box with minimal change of gate speed. So we're not expecting change in gate speed. You move without changing the speed and with good balance. Similar, the remaining similar to the last one that we did. Work with pivot turns. Okay, work with pivot turns. I think there is scoring for that. Turns with feet close, fast, less than 3 steps with good balance. So I see turns, feet close, so don't widen the, and it's fast. 3 steps turn. So it's some patients, because of the form that they have, they may take more than 3 steps to turn around. Because patients with Parkinson's disease, they take very small steps. So if they're turning around, it may take them maybe 5 or 6 steps before they turn around. But this one turns with 3 steps. We didn't look at the steps, but I know we talked just about 3. But we can try again and see. But now that he knows, maybe he will manipulate it. So moderate turns with feet close, but it's slow. So greater than or equal to 4 steps to turn, but there is good balance. Then severe cannot turn with feet close at any speed without imbalance. So that's, then step over obstacles. This one also looked at it. Then timed up and go with dual task. Many people do the timed up and go test. So we may not really do the time up and go test. But we know that the patient will be sitting. You say, when I say go, stand up from the chair. So you stand and then walk at your normal speed across the tape on the floor, turn around and come back to sit in the chair. So instruction, TUG with dual task. Now the dual task, count backwards by 3. So maybe we'll do this. You will count backwards by 3. So I will give you a number while you are doing this task. We have done it before. I think was it 2 weeks ago. You are sitting, it says stand. We'll have a point, you go there, you turn around, you come back. But this one, while you are doing it, you will be counting -3. So say, for example, 100 -3, 97, 90, you keep minusing 3, 6, 90, like that until you come back and you sit. So when I say go, stand up, chair, so I'll say go, stand up from chair, walk at your normal speed across the tape on the floor, turn around and come back to sit in the chair. Continue counting backwards the entire time. So you have TUG in seconds, dual task TUG in seconds. So 2 is normal. No noticeable change in sitting, standing, or walking while backward counting when compared to TUG without dual task. Moderate dual task affects either counting or walking. So it affects the walking. As he's counting, the walking speed reduces, the toning is affected, or the counting will now be affected. Because he's focusing on the tones and the walking, he will not be able to do the counting correctly. So then 0 stops counting while walking or stops walking while counting. So I don't think we need to do this because it's something that's straightforward. Yes, so we have 12:30. I think, can you give me any feedback? Do you want us to take 1 or 2 more outcome measures, or do we stop here? I don't see any feedback. Should I? Okay, so great. I say let's move on. Okay, so let's take that is final PDQ. Let's see that very quickly. So this is for quality of life. I think then it may need payment. That is why the one that I have here says sample copy do not use. But, and it is a shorter version. They call it PDQ8. There is another one that is longer version. I'm going to share that, but I'll just quickly show the shorter version before I share that. Okay, so this is the Parkinson's disease quality of life. Remember, I told you don't just assess patients at the level of impairment or activity alone, also consider the quality of life. So this is for quality of life, participation, had difficulty getting around in public, never, occasionally, sometimes, had difficulty dressing, felt depressed, had problems with your close personal relationships, had problems with your concentration, example, when reading or watching TV, felt unable to communicate with people properly, had painful muscle cramps or spasms, felt embarrassed in public due to having Parkinson's disease. This is for quality of life. It's called the Parkinson's disease quality of life questionnaire. There is a longer version. I will send or forward it to the forum. Then there is also, we have done freezing of gait. Then there is self-assessment. And this also is either activity or quality of life. So disability, this disability. So what we looked at earlier was handicap. This one is disability. So this one is looking at getting out of bed, getting up from armchair, walking around the house, walk outside local shops, travel by public transport. This looks more like participation, but it is under the activity here. So walk up the stairs, walk down the stairs. There are almost 25 activities, and you're going to rate them as able to do alone, able but minimally difficult, and so on. Very important to always assess patient at the level of disability and participation. So these are two outcome measures that can do that for you. So let's look at functional axial rotation, because they have problem with rotating axially. This is a study that I saw that is using an improvised equipment to do that. Yes, so it's a study, you see a clinical tool for measuring functional axial rotation. Margaret Schenkman, something like that. Physical therapy. This is an old one. This is an old one, but I mean, unless we have an update, it's something just to show you that with physical therapy, we can really use a lot of innovations. So I'm not going to describe it because the picture says it all. Let's look at it how they did it. So this is, we can have a meter here for measurement. And as they're looking forward, they turn around with something in the head that shows the point at which they have maximum axial rotation. Limit movement of the hips. So this is something I'm not sure, I've not looked at it. I think it should have an assessment of psychometric properties there. So that's for axial rotation. Concerning the outcome measures on balance, can we work with any 2 or 3 because of time constraints? So what do you mean 2 or 3? Do you mean in that particular outcome measure, just to pick 2 or 3? Because if you do that, it may not give you the full information that you need. If you think it takes long to use that, don't use that. You can now go and use something that is valid and reliable for use, and it doesn't take long time. Functional reach test is there. Back balance take about 10 minutes. I think maybe similar time with this mini test. But there are a number of timed up and go tests on its own has been shown to be valid. But now they are bringing it into this outcome measure to add the cognitive aspect to it. So you can't just pick one item from a whole outcome measure unless if that item has been shown to be valid and reliable on its own, separate from the whole outcome measure. So if you mean from that outcome measure, you can pick one and just use it, I would say it's not advisable because there has been no psychometric properties that removing one item will still give you what you need. But as I've said, there are many others out there that are not as rigorous and does not take as much time as this one. If the time is a problem to you, then you can choose those that have been shown to be valid and reliable working on their own. So that's what I would advise you to do. Yes, they wonder. So let me see if maybe we'll stop here. But physical performance. Okay, this one also is an activity Since I've presented another one, let me do this. Done self-assessment, final PDQ, graph, using of data, yeah, functional axials. Okay, so we can, I think we can stop here. Let me, if there is any question or comment, let's have it before we go on break. And then after 1 hour, I think from 12:45 to 1:45. That's what I'm using for data. Yes, so up by 1:45, Dr. Badaru will come in and he'll take us through the management aspect. So if there are any questions or comments, let's have them. If there is none, then I will hand over to the admin, the coordinator, to give any information if there is before we go on. Okay, so in the absence of questions or comments, say thank you so much, everyone. Have a nice day. Thank you, bye-bye.
Okay. Sì, sai come ci fosse che con le molti. No, ci ne for es ne baby. Marwar. Amma sai mishi anti malaria. Hey, okay. Hmm? Me.
Hello, please, we are sorry. The next facilitator will soon join us. He's trying to connect. He's having some technical issues, but will soon join us and start the presentation. So please exercise some patience. Thank you.
Hello, everyone. Uh, Hello, everyone. Please kindly be patient as the co-presenter is trying to connect. He's having a connectivity problem. So kindly be patient and
Good afternoon, everyone. Share video.
We can see
Hello,
the
good afternoon.
screen now. We can see you. Oh, good afternoon. Welcome.
So, we thank God for
We
everything
can
after
see
a
you.
lot of wahala. So,
Mm.
thank you.
It's okay.
So, alhamdulillah. Yeah, you are welcome. Please, a lot of wind and there is cloud in Kano. That is the reason why we couldn't connect on time. So, we thank God. Participants, are we together?
Yes,
Hello.
we are with you. We are with you, sir.
Okay. Going to look at management of patients with Parkinson's disease. My able prof has introduced Parkinson's disease, the assessment methods for Parkinson's disease. Now, general, what do you call it, management approaches for individuals with Parkinson's disease. Because it's multidisciplinary, there are so many disciplines that are supposed to be involved. By way of recap, we look at the overview of both motor and non-motor symptoms of Parkinson's disease. And as a form of revision, Parkinson's disease is actually a neurodegenerative disease. It keeps worsening with time. Therefore, it's a neurodegenerative disease that is caused by dwindling number or regression in the total number of dopaminergic cells in the brain, most especially in the globus pallidus of what you call it, the subcortical structure we call basal ganglia. It is characterized by rigidity, echinacea, bradykinesia, micrography. The rigidity of two types. We have the late pipe, we have the cogwheel. The cogwheel is as a result of imposition of late pipe on top of tremor. That is why we have the cogwheel. Echinacea, inability to initiate movement. Bradykinesia, slowness of movement. Micrography has to do with bradykinesia, normality, where somebody will have flex posture, where somebody would have a reduction in the range of motion of the spine, predisposed to having spinal deformity, and predisposing to frequent falls. Then we move to more actually disappears with the movement. But when the individual is at rest, the tremor will be apparent. The rhythm of 4 to 7 beats per minute. Then individuals with Parkinson's disease also present with marked face. There is like face of somebody who is, we used to call them cow face. Yeah, it's nothing like facial expression. We call it marked face. And then we later understand that actually there is also the rigidity and bradykinesia of facial muscles, only that it is not as apparent as that of the trunk and the limb. Then we now have locomotion, that is movement. All aspects of movement, most especially in the moderate, severe cases, are actually affected, involving initiation, involving alteration of direction. They have what we call absence of spinal reflexes. They cannot plan movements. They can to unplanned what do you call it, perturbations. Therefore, if you push somebody with Parkinson's disease, is going to fall immediately. Therefore, they have slow spinal reflexes. They have spinal reflexes, but anything that involves perturbation, they have to plan for it before it comes. Then, when the initiate gate is a big thing, and there is something we call motor block. That is what we call freezing. somebody will be walking and will stop walking immediately. Then that is part of the motor symptoms of Parkinson's disease. Then what we call the festinant gait or shuffling gait that is characterized by what do you call it? Short stride width, short stride length, and somebody is as if the patient will just be walking though slowly, but it's as if the patient is changing his center of gravity. And then if care is not taken, the patient is going to fall forward. Then there is loss of arm swing, poor foot clearance leading to fall. Then we have this big issue. This after the moderate cases, after 6-7 years of receiving treatment, or after 10 years of receiving treatment, some of them may actually have perception, attention, and cognitive. Here they have problem we have problem even with rehabilitation. You cannot approach somebody with cognitive deficit with dual tax. Tax specific training has to be what do you call it? Big tax has to be broken down into simpler tax because they have what do you call it? Attention problem. Then a perception problem. When we say perception, just like me sitting down and I see somebody approaching me, already what I saw in my eyes is like somebody is coming to hit me. That is what we think with perception. You walking and you see a stone, you move my leg, I raise my leg very well so that I shouldn't match the stone. Therefore, they have problem with perception and into interpreting what they see into what they call it motor action. That is perception. It's what do you call it area of what do you call it memory and the rest. Then we now move to non-motor symptoms. The non-motor symptoms of Parkinson's disease in sleep disturbance, orthostatic hypotension. This is very common. It's as a result of autonomic dysfunction, incontinence. We have sexual dysfunction, excess. That is one of the problem of what do you call it? Patients doing home based exercise. Their fatigue is actually not ordinary. A patient doing exercise for 3-4 days is a severe fatigue. Then we now have anxiety and depression, and that is actually fatigue these individuals have. Then that is by a way of trying to recall. We have the motor and the non-motor symptoms of Parkinson's disease. Now we move to the management. We now move to the management of Parkinson's disease. Is multidisciplinary, or can I say interdisciplinary? When we say multidisciplinary, we mean we are working together from different disciplines. We are not coordinating our treatment and giving at once. But when we say interdisciplinary, we mean we are coordinating our treatment probably in the clinic or elsewhere. Everybody will give his input. Whatever we plan for the patient is based on collective input. That is interdisciplinary. But usually in Nigeria, we do multidisciplinary. Every professional does what he feels is good for the patient. We only communicate with each other probably via papers. That is why I call it multidisciplinary. Then we have medical, that has to do with medications, surgical, that has to do with surgery, then physiotherapy technique, then we speech therapy, and other forms of treatment, like for example, visiting the psychologists, the psychiatrists, they are all part of what do you call it, the management of now medical management. This is the cornerstone. We have to say it. This is the cornerstone for management of patients with Parkinson's disease. The therapists will not be able to achieve what they are achieving with in the management of Parkinson's disease. There are some disabling symptoms that require these individuals. We now start, there are different types of drug classes. You know, the major issue with Parkinson's disease, dopamine. the absence of cells, neural cells that produce dopamine in the brain. Globus pallidus in the brain. Therefore, the aim is the dopamine. That is why we call it dopamine replacement therapy. The first aim of management using L-Dopa is to what? Replace dopamine. Therefore, and this is the gold standard. This drug, it is the best drug, the gold standard for the management of what? Parkinson disease. But it has one problem. The metabolism of L-Dopa actually starts before it 99% of it can be metabolized into dopamine before it reaches the place where the dopamine is needed. Therefore, now in the new treatment regimen, the carboxylase inhibitor, usually it inhibits this particular metabolism of what do you call it, L-Dopa, such that it will stay long up to the time it will cross the brain barrier and then in the brain. That is the advantage of administering L-Dopa. It allows for greater percentage of L-Dopa to enter the brain. Then we now have another drug. Okay, let's continue with dopamine replacement therapy. Therapeutic window is within 4 to 6 years before optimal benefit of dopa will wear off. Therefore, what we mean here is that for individual that is managed with L-Dopa that is converted to dopamine in the brain, actually the individual is going to have the full benefit of dopa treatment for 4 to 6 years, after which for that individual, meaning that higher doses of dopamine will be required. But higher doses of dopamine has a big problem. Before the higher doses of dopamine, what happened is that the individual, if the individual is receiving dopamine treatment twice in a day, and it's okay for the patient, now it will now reach, you will have started having the symptom. That means that individual have to be given dopamine 3 times in a day. Because it also brings about other, there are what you call stereotype movement pattern. Dopamine, high dose of dopamine. Example of it, example is atetosis. Somebody presenting with unwanted movement. Dopamine is gold standard, but they have to do something. They need some drugs. They will now be used in conjunction with dopamine, so that the patient will not have to experience what do you call it? Then we now move to what do you call it? Another drug. What do you call it? Class. It's an effective treatment for individuals with Parkinson disease, but it's an antiviral treatment. The mode of action is facilitated through the release of catecholamine, and dopamine is part of the catecholamines that we know. But together with L-Dopa, researchers have shown that it reduces the need for increasing the dose of good dopamine, meaning that for individuals that are on dopamine, what do you call it? Dyskinesias, then if that dopamine is administered, or L-Dopa is administered together with amantadine, it will reduce the need for high doses of what? Dopamine, and the patient is going to effectively participate in exercise. Then the next is dopamine receptor 2 agonist. They said D2 agonists used alone with L-Dopa also help in reducing bradykinesia and rigidity. Now, dopamine receptor 2 agonists. What they believe here is that it also increases dopamine in the brain. And it also helps to reduce the wearing off of dopamine. What we mean by the wearing off of dopamine, normally the patient is given, let's say, a dose of dopamine in the morning, probably a dose of dopamine in the evening, L-dopa in the evening. But before evening, the patient will now begin to. Therefore, what they believe here is when you give a dopamine, what do you call it, dopamine D2 agonist, what it does is it prolongs the half-life of administered up to the time when another dose will be needed. Then the third set of group is monoamine oxidase B inhibitors. Okay, what? It's part of the enzymes that helps to break down dopamine. Therefore, now when you administer oxidase inhibitor, what it does is it helps to slow the rate at which dopamine is being broken down in the brain, meaning that it ensures you administer L-dopa together with it, it will now reduce the rate at which the new dopamine that is formed will be now be degraded, meaning that it's reducing bradykinesia, reducing rigidity, reducing akinesia. It will serve the patient very well. They say patient in the early stages of may be given monoamine oxidase B inhibitors to enhance the degradation of dopamine in the brain. They gave an example of the drugs they are here, selegiline, also called deperanil. We have rasagiline. They said early monotherapy treatment with selegiline have been shown to have modest effect in slowing but not halting the patient. Yes, please, we have to understand this. Even physiotherapy, even chemotherapy, we actually help the patient to live a near normal life. We help to improve the quality of the patient. We help the patient to be able to do his activities of daily living. We help the patient to be able to move with ease. But actually, the disease is progressive. No matter what, the disease keeps progressing. Only that all these treatments can slow the progression of the disease, and the patient will live a. Okay, then we now move. We now have, then why are we really interested in all these treatment techniques? We are interested in these treatment techniques because we as we would do a futile effort. The patient is going to suffer. We are going to suffer without the patient being on the proper medication. Physiotherapists, the patient come with intense, with excessive rigidity. The patient comes with muscle pain. The patient comes with what do you call it, excessive bradykinesia. The patient comes with what do you call it, and the patient is going to suffer. What they are telling us is we should plan our treatment. We should know the medication the patient is taking. We should know when the patient is taking the medication. We should know when the patient is feeling okay, he is going to participate in your exercise. And when the medication is started to go down, and we should give the therapy exercises. We should give the therapy treatment. We should give all forms. Not when the patient is on what? Off. When the patient is on off, it means gone. The patient has started having the symptoms. Then in that particular sense, when the patient comes to you and he is not likely going to get anything. But when you time the treatment, when the patient is on, meaning that 1 to 2 minutes to 1.5 hours after he has taken the drug, everything will be okay. Is he taking a dopamine, what do you call it, a monoamine oxidase inhibitor that will prevent degradation of dopamine? What do you call it, the release of dopamine, like amantadine? Is he taking a dopamine replacement therapy like L-dopa? What is the patient going to come such that you enjoy the therapy and he is also going to enjoy your treatment session? Then it is important for us to know that all surgical interventions are administered on patients with severe, at the chronic or late stage of the disease. After the patient must have suffered for 20 years and he is not improving, the bradykinesia and everything is disabling, the patient is starting to become bedridden. That is when surgical intervention is required. Surgical intervention is not meant for mild to moderate. Therefore, the two surgical interventions that have been mentioned in the literature include thalamotomy and palidotomy. Thalamus, palidotomy has to do with removal of, or partial removal of what do you call it, some part of our globus pallidus. Then we have, they said thalamotomy, but does not treat what do you call it, bradykinesia or rigidity. Call it palidotomy. That is when part of the globus pallidus is being removed. It is helping in levodopa having dyskinesia, but as a result of high doses of what? Levodopa or L-dopa, then when they did palidotomy, all the dyskinesias he has, what do you call it? It may be, what do you call it? It may be choreatetosis, it may be atetosis, it what do you call it? Suppressed. Then we now have deep brain stimulation. Deep brain stimulation is actually a surgical procedure. It involves implantation of electrodes that cause symptoms using high frequency stimulation. Just like we have all physiotherapists know about pacemaker. This one is just like a pacemaker. It will be implanted under this sub generator will be implanted, what do you call it, in the subclavicular area with wires that go under the skin. And the individual can be trained to be modulating the current. But the issue is that deep brain stimulation is actually very effective in the management of what do you call it, individuals with persistent fluctuation in motor function and dyskinesias. They said it's very, very important. It improves rigidity, bradykinesia, akinesia, as well as gait and balance. The first risk that is associated with all surgeries. It can lead to infection in the brain. It can lead to intracerebral what? Hemorrhage, because you are entering the subcortical structure, the basal ganglia. You are opening it. You are inserting something inside. Another issue is what? Mechanical problem. The device may become what? Faulty or malfunction. Then we now move to physiotherapy approach. That is similar to this one. It's what you call non-invasive brain stimulation. The success of deep brain stimulation, and most especially in countries like Nigeria, where we may not have the technical expertise, we don't have the equipment to do deep brain stimulation, and there are researches all around the world. You can check internet. There are non-invasive brain stimulation that are being under research now. Example, we have the transcranial magnetic stimulation, and we have according to a recent systematic review conducted in 2023, 2021, please, it has shown that these non-invasive brain stimulations actually they accompany what do you call it? Parkinson disease. What they mean that when you administer non-invasive stimulation, rigidity, akinesia in this patient. Therefore, it's worth trying. They said recent randomized control trials have shown promising outcomes in the treatment of what Parkinson disease symptoms using it's worth trying as physiotherapists. If you cannot do deep brain stimulation because it involves surgery, then we can also try, even in our researches, we can try non-invasive brain stimulation. Okay, we now come back to physiotherapy approaches. Are we together? Hello, are we together?
Yes, yes, sir. We
Hello.
are with you.
Okay.
We are with
Now we now go to actually
you, sir.
I rushed to because of the deep brain stimulation. That is why I rushed down to non-invasive brain stimulation, which is in the repertoire
Yes,
or physiotherapy practice.
yes,
Then we now have physiotherapy
yes.
approaches. Now,
Mm.
please, there is no approach that is, can I say, panacea to all the problems with of individual with Parkinson disease. Individual comes with. Therefore, there is no treatment, can I say, that can go for everybody. It depends on what you have assessed in the individual in your objective assessment. Therefore, the degree of severity of the disease must of your careful objective assessment of the patient also determines what you do to the patient. Therefore, if we revise stage 1 and 2 using the Ho and Ya scale, I don't know. We have the Ho and Ya scale is the one that we use in the staging of the severity of the disease. Unilateral. The symptoms start unilaterally, affecting only one side of the body. They have little rigidity, little tremor, and all these guys are on one side. Where the symptom now started becoming bilateral. Somebody now is functional, but actually we have modified dependence because the individual needs some help in some functions. We call them modified dependence. Here we need more, the patient is more and more dependent. But unlike 4, 5 are usually bedridden. Then we now have the outcome of careful assessment. Most especially those people that we know came with, individual may come with mild Parkinson disease and you feel is very autonomic dysfunction. Until you now begin to, put him on treadmill, you now begin to see you are exercising a patient, but is hypertension because of affectation of autonomic function. Therefore, you have to assess this patient. You have to assess for the presence of arrhythmias. Usually, we as physiotherapists, we assess for heartbeat, that's the pulse rate, and then we'll also assess for rhythmicity of the pulse rate. When you're assessing somebody's pulse rate and the pulse stop until after, let's say, some seconds, something is wrong with it. Probably you need to refer that person. Then we now have fatigue level. Is this individual easily fatigued? Their fatigue is so psychological. If somebody is being exercised without, after 3 days, I will be able to exercise again. Then we have to know this one. Assessment, careful analysis of balance, posture, obtains fall history. All these ones are very important. They are akin to good management of patient with Parkinson. You don't know where go with the patient. Then this is I'm just putting this one for please, RPE is rate of passive exertion. We use what you call the box rate. We have RPE, a scale of, we have a scale of 6 to version and the shorter or revised version. Please go and read about RPE, rate of passive, rating of passive, or bulk rating of passive exertion scale. Then a year scale that we said, look at it between 1 and 2.5. Those ones are the ones we call they have mild symptoms. 3, individual has moderate disease, may be physically dependent, not physically dependent in the sense that somebody would have to do things for him, but we call it modified dependent. Somebody would want to do something, but clearly he is having difficulty, you have to help him. But those ones that are dependent are the 4 and 5. 4 is severely, individual can stand, that individual can take some steps. It's better than somebody who is on wheelchair and bedridden. That is the 5. Then we now have physiotherapy in early stages of Parkinson disease. And remember, we said it depends on your assessment of the patient and it depends on the stage. Generally, all we are aiming in the early stage of the disease, the individual does not have much impairment. Even the symptoms and signs are unilateral. They don't prevent him from doing anything, only that he feels the hand is shaking, he feels so tired, he has started. Then what do we need to do in this particular case? They said our aim is to improve fitness level and delay or prevent direct impairment. Therefore, we don't want akinesia, bradykinesia, we don't want rigidity. Therefore, all we want to do is to ensure that this individual, we improve his fitness level, both both cardiopulmonary endurance, both muscular endurance, we do that. Then the second thing is we increase the strength and range of motion, especially of the trunk. Immediately somebody comes with Parkinson's disease, even if it is not now, but after some years, he's likely going to have, a rigidity of the trunk muscles. Definitely, you now institute exercises that involve the trunk to increase the strength of trunk musculature right from the beginning. Then maintaining and improving chest expansion therapy is very paramount. Part of the causes of death of individuals with severe Parkinson's disease is pneumonia and respiratory issues. Therefore, chest expansion, please, I have read in so many literatures that breathing exercise should be part of all managements. Whatever the patient does every day, the patient should be able to, you should incorporate breathing exercise in the management. Then we have to improve balance reactions. Yes, even if it is not now, later the patient is going to have impairment of balance. It's better we institute balance exercises right from early stages of the disease. Then we have increasing movement may in fact modify the progression of the disease and may further help to retard dementia. Yes, actually, when you institute, most especially aerobic exercise, go and read so many literatures on aerobic exercise. It has, it's very effective in improving mood. It's very effective in improving memory. It's very effective in the management of depression and anxiety. Therefore, when you include this, for the individual that is likely going to have at the tail end of the disease, develop dementia due to the disease, that would retard the development of dementia. Okay, now we have this table. This table is summarizing early stage Parkinson's disease with the appropriate intervention strategies. We have under common impairment and activity limitation, the individual we say is independent. He has few or minimal impairment, few what limitations. Probably somebody says, when I want to hold something, my hand keeps shaking. Or somebody says, before I used to walk very fast, but now my walking is becoming a bit slowly. Just few impairment. Movement symptoms may present, but may not interfere with any activity of that individuals. Then we now have okay, now somebody was asking about aerobic exercise. That one should be inside a exercise class. We'll explain later. Then we now have changes noted in posture, walking ability, and facial expression. It's very possible. Somebody may have started experiencing that he is still walking. Somebody may now look, yes, the facial expression has started changing. You don't see the smile, you don't see the laugh in the face, though it does not have max face, but actually it has started expression in this guy has started going. Then this is the phase where Parkinson medication affected who is put under L-DOPA medication. All these symptoms can be suppressed by L-DOPA. That is what we have said. Initially, why this Parkinson disease will remain with the doctor for 5, 6, 7 years is because L-DOPA medication used to suppress all these symptoms. But later, when L-DOPA wearing off now started having impact on the individual, when the complication when complications as a result of high doses of L-DOPA have started manifesting physiotherapy. Then for our intervention, we need regular exercises to improve and maintain motor performance, strength, mobility, flexibility, everything you want to do to the patient. If it comes at the early stage, you must do it because those ones are very, very important. Then they said we should also involve community classes to maintain socialization and positive outlook, meaning that if there is community class for those that are doing community physiotherapy that is meant for individuals, group exercises for Parkinson disease, it's going to help socialization and positive outlook. Then we have compensatory strategies. We said we need education about the disease, meaning that the patient that comes, you have to tell him about the disease. This is a mild disease, a progressive disease, but actually what we are doing is going to well, it will take long before you lose ability to walk. People that used to come to the therapy department will definitely look for a longer the disease, educate him about what do you call it, dopamine and dopaminergic medications he has. What is the role of the medication? Educate him on when to come to physiotherapy after he has taken drugs so that he will enjoy the treatment. Then it may also need us to refer the patient. Yes, when the patient needs psychological support, you refer him. When the patient needs occupational therapy to be involved, you can send him. The patient cannot wear clothes. Probably you must have done your own. The occupational therapist would help you do that. The patient needs the service of a nutritionist. Yes, because the patient is always on high protein diet, and high protein diet actually used to affect the effectiveness of what do you call it, L-DOPA treatment. You have to take him down to that to the nutritionist or refer him to the nutritionist that will prepare something for him that will reduce the amount of protein that he takes. Okay. The next stage is the middle stage of the disease. Here, that is the stage 3 on year scale, whole and year scale. Stage 3, the symptoms and activity limitation are more apparent. Here, it is very apparent. The independence in gait, performance is slowed and less efficient. Though this individual, yes, we are going to come to the diet, we are going to discuss it. Therefore, though the individual is independent, the individual can walk. The individual can go to his work, can do everything, but this individual will tell you, if I climb 3-4 stairs, somebody will have to help me. Somebody says, even to run across what do you call it, a busy for me, somebody will now we have what you call modified dependence. Though one is functional, but in some activities, somebody will help him. That is stage 3. Therefore, what do we need? Here, we need more regular of the therapy that you know that will help this patient. They have to be at place this moment. They said regular and intensive physiotherapy is needed, and this has been shown to be effective in improving general motor performance. Here also, you need family and caregiver instruction. They should intensify their assistance to the patient. Somebody needs to be what? Fully independent as possible. Therefore, it's not just the patient. When the patient cannot do something for by himself, then somebody who is being trained by the physiotherapist, who is being coached by the physiotherapist should help the patient at home. Meaning that management of individuals with Parkinson's disease requires educating both the patient and the caregiver right from the beginning. Then here in our table, like the other table, we have the common impairment and activity limitation in individuals with moderate impairment and our intervention strategies. Here, we have increase in number and severity of impairments. Yes, somebody will now begin to tell you that I don't have, like most especially the non-motor symptoms, I begin to have constipation. Somebody will tell you that I'm actually depressed. Somebody will begin to tell you that actually I am having muscle pain. Somebody will now begin to tell you that my hands are becoming stiff. Or if somebody starts to, yeah, more and more impairments will now be apparent. Then I said moderate activity limitation, participation restriction. What do we by moderate activity limitations and participation restriction? Somebody can do some, somebody cannot do some. Please, what we mean by activity, what do you call it? What do you call it? WHO definitions of disability. This limitation, meaning that individual experience moderate disability. Handicap, meaning that go back to the modified definition of what do you call it? ICF, ICIDH. You now see participation restriction means what? What do you call it? Participation restriction means handicap, meaning that somebody experience moderate handicap and moderate disability. That is occur bilaterally. Before, it is only one hand that is having what do you call it? Tremor. One leg, rigidity. The other leg is now having also rigidity. Bradykinesia is apparent in both legs. Everything. Then they said postural instability. It is telling you that individual now begin to have stiffness around the trunk, meaning that it is easy for this Parkinson disease to experience fall. It is easy for him to fall down. It is easy for this individual to experience freezing as he is walking. Most especially, one cause of freezing is individual walking and you startle him. In outside, they say another issue is when he walks in a very narrow path. You have to, when you are exercising patient, you make sure that he is walking, the place he is around, asked to walk, should be so spacious. If not, he is going to experience freezing. Another cause of freezing in these individuals, when you have somebody, you know, they have moderate, like most especially with severe deficit. Therefore, when you present so many tasks before individual, do this, the next thing somebody will become confused. And that is what we call it motor, what do you call it? A motor outage. Somebody will now freeze. Motor freezing is one of the problems with moderate. Then we have medication may wear off. Yes. Now remember in the mild cases, we say medication takes care of all their problems. Therefore, there is no need. Most of the doctors don't even refer them to physiotherapy because medication take all their problem away. But with moderate Parkinson disease, the medication is supposed to last for 3 hours or 4 or 5 hours, and the patient will feel okay before he takes, and the dyskinesia will now become apparent. Therefore, what do we need in that particular case when the medication wear off? Either to increase the dose, which is going to increase dyskinesia, or to now change the medication, or we now advise the individual to go back to the doctor to revise the medication so that the individual will come stiff and we are not really going to enjoy the treatment. We have preventive and restorative. When we say preventive, that will prevent further deterioration and damage. Probably the individual now does not have any compromised range of motion. The individual have any contraction. The individual does not have any chest complication. Therefore, first part of your respiratory exercises, when you do what you call it, endurance exercises like walking, you are improving what you call it, muscle. Then we have restorative. Somebody is having problem like relaxation techniques. Somebody is having what do you call it? Somebody is having rigidity, like cobble rigidity or leg flap rigidity. You need to, the patient will suffer pain and will suffer, and you may not even want you to manage him when next he comes because he's going to suffer pain. Then we now have electrotherapy management, like let's say infrared. It has been documented that after relaxation technique administer on the individual, it helps to relax the muscle and relax the patient, and you also enjoy the treatment. Then you do use augmented feedback, the one we call cues. mobility, flexibility exercises. We have community classes. Remember, like the first community classes, where do we get community classes? We need physiotherapists that are working in the patient with what do you call it? Parkinson disease, such that this individual will not be staying at home, such that this individual will have somebody that will be taking care of him, and you will see people. Yes, it is not only me that has this disease, and I'm socializing. That will prevent him from getting depression. Okay, then compensation, maintain function. Here, I want to talk about assisted in patients with Parkinson disease. We should understand this. I don't have slide for assistive device. There is no specific assistive device to be Parkinson disease assistive device. Number one, any assistive device that will help Parkinson disease patient is required. They said any assistive device that would help individual to walk upright, meaning that if you are giving individual a pole, 2 poles to hold, if you are giving individual rolling walker that has tire, that thing should be able to help individual to walk upright. Having stoop posture, their shoulders are flexed, their back is flexed. Posture is not needed. Kinesia, bride kinesia, and there is what you call that used to happen to them. It's usually difficult. They may start walking, but stopping walking is another problem. They give somebody a walking device, most especially those that have time, the patient is going to be injured. You have a break. That the rolling walker must be in such a way that the height should be the length or the height to stand upright. The next thing to consider is that requires the patient to, because these people don't have balance. Therefore, any assistance need. But the one most especially like what do you call it? Say working frame, something like a rollator, like pole to stand upright. Stage, that is the advanced, is fully dependent in most of the day. Requires help in going to the toilet. The patient requires help in eating. The patient is always on wheelchair or bedridden. This was deep brain stimulation. These are the people that requires all these guys. These are the people that require prevention of secondary complications. Here, of chest physiotherapy, you have to do a lot of stretching. You have to do a lot so as to prevent pressure ulcers. There is increased demand of care what do you call it? It's also social isolation. Somebody takes or is a patient with what do you call it? What do you call They said we physiotherapists we need to maximize psychosocial support. The family, we have to tell them things that will encourage. That is the last stage of the disease. Here, impairment, they said the patient wheelchair and bedbound in most of the day. Cognitive, including dementia and hallucinations. This is the end. Incorporate aerobic exercise. What should incorporate what do you call it? At the tail end, the individual is likely not going to develop depression, complications. Then they said increasing medication. Yes, the individual does not go anywhere. Therefore, there is tendency for medication intolerance. So we should maximize upright posture and out of bed time, meaning that we should encourage the individual to stand as much as we can. We should encourage we should increase the individual to be out of bed in order to we try to always get the patient out of the bed. Activities of daily living, no matter how little can work, we should encourage him to work. The individual can wear his clothes. If no matter how little, we should encourage that. No matter how little, if the patient can attempt eating, we should encourage that. Then they said then we say compensatory caregiver education is also needed at this psychological support, psychosocial support. We have to train them on transfer, positioning, turning, and skincare is very, very important. Okay, the next is stimulation. Then we are now going to look at few of all those techniques that we talk on the table. We are going to look at the techniques. The first, okay, now there is something people should understand. Individuals with Parkinson's disease, gentle rocking. If you have a chair and you keep rocking the patient from left to right, left to right, left to right, before you know it, that rocking exercise will relax the patient. It is going to reduce the rigidity and bradykinesia in the patient. They said many relaxation techniques are effective in reducing rigidity. Slow rocking, rotation of the extremities and the trunk, and the use of yoga. Somebody will say, how do we rotate extremities and trunk? And ask somebody to lie down, have crook lying position, or just as if that individual is going to do bridging. In that bending position, you can be rocking the leg from left to right. It will relax the patient. Please, I have seen in so many down on the side of the bed, and you turn the patient to look shoulder. Turn the patient to look towards his right shoulder. Redeem it. Still rocking, and then what do you call it? Mobilization of the used to reduce. Therefore, try that one. Relaxation used initially, meaning that we should make it part of our treatment for patients with Parkinson's. What do you call it? Relaxation exercises. We should give them gentle rocking so as to relax them before we do anything. But remember, what? Levodopa or L-dopa. What do you call it? Dyskinesia because of what? The off period, then you should encourage. Relaxation training is better conducted in sitting or standing supine position. Now, this is yes, this is have rigidity. The rigidity tend to increase position. Try as much as you could your relaxation exercise. If you are doing the toning exercise, if you can also do rolling, supine position. Rolling is not supine because it also increases what? Rigidity of the distal muscle in the rigidity. Therefore, proximal movement, meaning that you should start mobilizing. The highest rigidity is found in the spine, from the extremity towards the spine. The relaxation continue. There's a PNF technique of rhythmic relaxation, rhythmic initiation, active assisted to slightly resisted with Parkinson's disease. Another one is they said in a supervised water may be relaxing and the biopsy may enhance. Have the opportunity to use hydrotherapy can reduce rigidity in this patient. Then they said it's also relaxation technique, Jacobson relaxation technique. You can. Then the next thing is, before we start everything, is flexibility now, meaning that they are telling us before relaxation, start flexibility, range of motion exercise. All sorts of flexibility exercises improve range of motion and physical. If the muscles have been warmed with active, I've said this. Therefore, you can warm the muscle, gentle prescribing exercise. You know, they said in the duration of exercise and the cool down. Therefore, what you are giving this patient, they said this patient with breath, he needs some warm up. Just give him warm up, even if it is in form of assisted active exercise small. They said exercise to improve range of motion of the spine. We are talking specifically to the spine movement as opposed to stretching. How much can you stretch the spine? But in a way, when the patient lie down, deep, and you can be turning the legs the way they are flexed to be turning the shoulder left and right, you can modify the spine. That is to modify to mobilize the spine. Then when you try to use exercise, also be used to what? Stretch tight muscles. Therefore, you can help the patient by position in a particular place can be what? Stretched. Then here, okay, they said to reduce tightness along the joint capsule. Then somebody will say, yes, yeah. Am I going to do what do you call it? Sustained passive stretches of the. Should I combine sustained passive stretches of the tendon Achilles and also mobilization of the ankle joint? We should stretch the tendons and we should also mobilize the joint. That is what they said. A combination of static and dynamic. When you ask the patient to do active what? Range of motion of the joint. So facilitating with what? PNM can also help the patient. The flexibility exercise should be performed 2 weeks. Okay, now what you come to our mind, we hardly will we treat this patient more than 2 to 3 days per week. Is that also days per week? Meaning that in essence, what is required for stretching exercise, what do you call it, as form of what? A form of home program. And then normal caregiver should be taught how to do it correctly. Per stretch and hold for 15 to 60 seconds is recommended. what do you call it, tendo Achilles. As she stretch in 15 to 16 seconds, I release, stretch 2, 15 to 16, 3, 4. Then I am able to do that. They said we should hold for what? 15 to 16 seconds. Recommended. Then functional training. This is what functional training. When somebody comes with moderate, prevent him from going to severe. Because generally we don't see patients at mild stage, except some few. Our help. Remember, we said in mild cases, the doctors will prescribe dopamine and what they call it L-dopa, which will combine. It is later when L-dopa now begin to have the wearing of effect, on and off effect, dyskinesias, and definitely the physiotherapists will now be involved. Now, to come with moderate disability, they said the first one, we should give them motorized treadmill. Motorized treadmill has two important, very, very important fitness. It improves muscle endurance and it also improves treadmill training, with or without overhead harness, improves postural stability, step and stride length. It also improves motor function in the leg. Here, et al. Found that the gains in walking speed and the number of steps were maintained after 4 months. After the treadmill, every day the individual has maintained it. The treadmill speed may be rhythmicity and gait variability. Is when you put the patient that actually, when you put him on treadmill, can he stop taking rhythmic steps? That is what they said. Because the patient cannot stop. The patient will not have, it makes the gait have what? Because the individual is taking step at a time and in a controlled fashion. They said treadmill training with what? Cognitive on patient. Some patients cannot doing treadmill training. Treadmill training, and at the same time, if the patient cannot just do treadmill, you can combine treadmill training and cognitive stacks, and they said it improves falling. Okay, now we in structural sense. Okay, what are these ones? We mean the language. We talk to the patient. You remember we said they have what you call, if they are not opening their leg, short steps. For reciprocal arm swing, they work as if they are have the reciprocal arm swing we see. Therefore, you now swing high. As the patient is swinging his arms, walk fast. As the patient is walking, the gait is increasing. Take large steps. They are telling the patient, if it's telling the patient to open his leg, and they said, walk and watching his legs. The most important thing is, and then raising his shoulder, such that caused by rigidity of the spine will now be reversed. Swing your arms. They are what you call basic use. Then the next thing is what? Marching in space. Improve the height. The raise. You know, we have what you call in the gait heel up. We have what you call toe up. For the individual to have a very high mid swing in the step, at once. That matching is also going to help patient to have rhythmic movement. Short gait as if he is chasing the center of gravity, the way in which you control the movement. There's a matching in place to walking using what? It high stepping pattern. Then they said it can also be used. What is brisk marking music? You can have a music and somebody will be following. You'll be walking briskly. They say it do help. Is another effective style. But patient walk with vertical poles. We have said it. You can have two bamboo. Help the bamboo. The bamboo should be tall, should be taller than the patient. The bamboo should be taller than the patient. The patient as if there are two walking sticks he's using. The bamboo should be very tall. That he will not have the need to be watching his toes. Upright alignment. Then now another exercise, another activity is balance and coordination training. This individual, our patient with Parkinson's disease that have moderate or severe disability used to. Therefore, balance training should be incorporated right from when the patient is having mild impairment. They said example of for those that know ballroom dancing, two people will be. They said it incorporates rhythmic movement, rotation. For those of us that are used to Tai Chi, they said it gait and balance parameters. And then quickly is important. You are not going to be walking slowly all your life. You are not going to be walking. This is where you'll be walking slowly and something will come, you have to walk fast. They say we have to be teaching this automatic reaction. They lost postural and automatic reaction. You're definitely going to hit them or they are going to fall. But they don't change direction automatically. They have to plan for it. As they are walking slowly, you now say, okay, now quickly, now slowly. It is to be able to attend to what do you call change in motor function. Then they say training the patient to step in response to perturbation. Yes, when you push when you push a patient with Parkinson's disease, him that I'm going to push you, let him know that you are going to push him. He should be able to resist your pushing. As you resist the patient, if you do not inform the to do and you perturb the patient, then they said in such cases that perturbation is contraindicated. That I am going to displace you and you are going to let him know, then that will be more helpful to the patient. They should focus their attention on what? Maintaining balance. I've said it before. Balance before attacks in which equilibrium is what do you call it? Focus your attention. I'm going to put you on therapy board. On this particular, the two legs, I want you to balance up while holding your two legs. Let him pay their attention very well. You shouldn't do anything uninformed because it increases rigidity in them. Then they say we should practice weight shifts. The patient is standing. Your weight to what do you call it? The right leg. Okay, shift your weight to the left leg. Can you stand on one leg? They say reaching. Can somebody reach forward while standing? Rotation of the head and trunk. Can you turn while standing and look look at your left shoulder. Then they said, seated, for example, altering the arm and leg position. You can ask the patient, what do you call it, to reach. You can put the feet together. You can do tandem walking, one leg in front, one leg behind. Then we have adding voluntary, what do you call it, voluntary movement, overhead arm clapping, swing. Okay, therefore, when you encouraging arm movement, head and trunk rotations, single leg raises. Then they said, what do you call it? We have the use of what you call augmented feedback. It's another form of functional using what? External cues or augmented feedback. That did not come from your joints, that did not come in form of what do you call it? In form of what do you call it? Interoception. All these guys are exteroception, interoception. They are all augmented feedback. It may be in form of visual cue. You touch patient and he knows what those ones are what you call cues have been shown to be effective in improving movement characteristics in patients with mild to moderate PD. Another cornerstone, cueing. Parkinson disease, you have to use cues. We start with visual cues. We use station Frankel exercise, Frankel mass. Some exercise is a cue. We are not saying you should. Disease, you can make a markings. This individual is working with very step length. You can increase the step length. You can put a masking tape. Okay, you match on this such that you improve. That is what the patient is working on the marking and the what do you call it, the that is what you call transportable cues. You can use laser light signal. When you flash the signal, he will be following the signal. This is not stationary. This is dynamic. The patient will not be seeing the signal and the patient is following it. This one is dynamic and start now follow it. It will be follow yellow as he's following it, walking, and it will be improving. They say visual cues have been shown to improve stride length. They said they also what do you call it? They reduce freezing episodes. Yes, actually, one of the ways to reduce freezing episodes, what do you call it? Visual cues. Like, for example, if you have a patient that freeze, what will you do? Will you just drop something on ground, like handkerchief or anything, and say, can you step on this handkerchief? The next thing, the patient, we don't tell the patient, we don't catch the patient when the patient and tell him, can you step on it? Something like a paper or anything, then the patient would to unfreeze a patient. Then we have auditory cue. We can use sound. Ding, 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 ding. We can use a metronome or a music to improve stride length or speed. Is walking, ding, he will now follow the metronome. Ding. Taking step in line with the metronome or the music. The beat is typically they are saying If the patient is walking at of 60 revolution per minute, or it's too big in the metronome. Okay, this is so that you can encourage the patient to walk faster. That is what they mean. As big step can also have to improve gait. What do you call it? There are some instructions. Walk fast. We can say walk tall. It's also an auditory cue. Big step. They mean cues should be consistent, not rush and have rhythmical. What they mean by consistent is that if I am saying take a large step, I shouldn't be saying open. I should be consistent in the using of what terminology. Then I shouldn't. They said for patients with advanced disease and severe reduction in stride, and it's not even effective for patients with dementia. Patient that does not follow instruction, you cannot give him cueing. The cueing has to do with somebody answering. If the patient actually is having dementia and is having what you call it, practice cueing on that patient. Here, what they are saying, patient lack facial expression. Even when you make have there is what you call it, bradykinesis and rigidity. They say should we leave the face like that? To reduce the bradykinesia and rigidity. They say we should massage the facial muscle. We should stretch the facial muscles. We should use manual contact so that the patient will feel verbal cueing to enhance facial what do you call it, movement. You tell him, can you smile? Oh, frown. You call it, raise your eyebrow. Can you when you are doing this, following you. The say patient should be instructed to practice lip pulsing, movement of the tongues. They say a mirror can be used to provide visual feedback. The verbal skill, breath control. Verbal cueing, if somebody is having dysarthria or anything, but this is not in the repertoire of physiotherapy. Then we have strengthening exercise. Based on literature, they say it's not very obvious in patients with Parkinson's disease because of rigidity, in stroke. You feel that the lower limb of the patient with stroke is strong. It's not strong. It is the severe spasticity at times that you to help patient walk on the leg. But actually the leg is weak. That is what is happening. Then they said you need high resistance eccentric exercise. Please, we should hear this. Please, co-contraction. Isometric exercise is contraindicated in patients with Parkinson's disease. Isometric exercise, any exercise that involves contracting both agonist and antagonist muscle is going to increase rigidity. Rigidity is the co-contraction of both agonist and antagonist muscle, while spasticity is what you call it, is unidirectional. One group of muscle is having spasticity, the other group of muscle does not have spasticity, like spasticity of biceps muscle. So somebody can easily flex the hand because it's in the direction of spasticity. But extending the hand will be difficult because it's going against the direction of spasticity. But rigidity, both flexion and extension are difficult because both biceps and triceps will be rigid. Therefore, strengthening exercise should be what? We need eccentric. Please, they did not say concentric. Eccentric what? Resistance. Somebody is using weights, but actually not isometric weight. You don't stop. Don't ask somebody to lift weight and hold. That is isometric contraction. If you do that, it's going to increase rigidity. It should be isotonic and eccentric. eccentric in such a way that it will increase the length and range of motion of the joint while also increasing the muscle bulk and strength. Okay, they say spinal extensors need to be exercised. Spinal flexibility likewise encouraged. Therefore, you should encourage the patient, most especially the patient is having stoop posture. Somebody is flexing. You should encourage the patient to lie down prone and should be able to raise the shoulder. When somebody lie down prone and raise the shoulder, it's going to extend the back and the spine. Then resistance training improves muscle strength and motor unit recruitment. It also improves the rate of force development. Specifically, it also improves anti-gravity, the strength of anti-gravity extensor muscles. Therefore, you should encourage individuals why they are having stoop posture is because the anti-gravity muscles in the spine, the back extensors are weak. Strengthen them. The leg extensors, like quadriceps, strengthen it. The gastrocnemius soleus and plantaris, the plantar flexors, strengthen them. All anti-gravity muscles, strengthen them. They say strength training has also been shown to improve muscle force, bradykinesia quality, and quality of life in patients with Parkinson's disease. Then they said task-specific training. This is part of what you do to improve function in patients with Parkinson's disease. But what differentiates task-specific training with other forms of training? In task-specific training, we define it as a form of therapy where patients practice context-specific motor tasks and receive some form of feedback. What is this context-specific motor task? What is feedback? Task-specific training requires what you call real-world object manipulation. All these ones are part of task-specific training. Let me break them down. The first one is, say, context-specific motor task. What is context specificity in task? You want to wear clothes. Somebody say, raise your hand. You want to wear clothes. Somebody say, raise your hand and bring down. Will that lead to wearing your clothes? No. Then meaning that somebody should bring clothes for you and train you to wear clothes. That is task-specific training. You want to use your hand, and they said, okay, you want to use a spoon to eat food. And somebody say, okay, he has a very good grip strength, then he can eat food. No. You should bring a spoon, even if it means adding sellotape to the spoon so that somebody should be able to hold it. Then you train him how to eat food with the spoon. That is real-world object manipulation and context-specific. Then that is it. Somebody want to bath. Then you should train the participant how to help him enter the toilet, how to help him bath. That is context-specific. This is not just from functional exercise, but what? Context-specific. Somebody want to achieve something, you help him to achieve it. That is context-specific. Somebody says, I cannot climb stairs in my house. Therefore, the issue is that you either follow him to the stairs or you now use stairs in your clinic to teach him how to climb stairs, and you now teach the relatives how to help him climb stairs at home. That is context specific. They said task-based model of intervention can enhance skill learning through identification of tasks. Please, in task-specific training, at the tail end of every movement, there must be a task that is achieved. If you raise your hand up, that is functional exercise. But if you raise your hand up and remove somebody's cap, that is task specific. If you raise your hand up and plug mango, that is task specific. If you move your hand in air, that is functional exercise. But if you move your hand in such a way that you write with biro, that is task specific. Then we should also learn to help patients achieve task-specific exercise. Then the next, and then they said we should give them what? Feedback. What is this form of feedback? You tell him you have done well. You clap for him. But next time you should do this. That is what we mean by the feedback. Then the next is home program. Home program should encourage moderate, consistent exercise as part of what? In the normal day, meaning that there must be something the patient must do every day. You must design home program as part of everyday activity of the patient. The patient does not have time to come to you all the time. That is why when they said you should do stretching 5 to 7 times, we said stretching should be part of what? Home program. Then they said fatigue should be avoided and the exercise graded to the individual's capability. Yes, Individuals that are having non-motor symptoms, severe symptoms like fatigue, we should space out. Exercise for 3 minutes, rest for 4 minutes. Exercise for 3 minutes, rest for 4 minutes. We should teach patients also to be doing that with time. At times, that is also, let's say, has to do with the cognitive functioning of the patient. The patient may have some cognitive impairment. That is the reason why this persistence may be persistent. The patient and caregiver should be instructed in the appropriate stretching exercise. We said it. Stretching should be part of what do you call it? A whole program. They should be instructed on that. Remember, rigidity can lead to what? Loss of range of movement and what do you call it? And contraction. That is why it has to be done. They said all mobility exercise should be performed in the home setting with the help of informal caregiver. The patient shouldn't go out and be saying, most especially those with moderate to severe, they must always be accompanied by somebody because of fear of fall, because they don't have automatic postural reaction. Something may happen and they require them to automatically react. They may not be able to do that. Somebody should be with them. Then we have nutritional management. They said high protein diet reduces effectiveness of L-DOPA. For individuals taking methyl dopa, if they are taking and it's not working, it's very possible this individual is very rich. He used to take wake too much, that is beans too much. He used to take beef too much. He used to take all these proteinous things because he is very rich. They said it's what? It's what do you call it? It competes with L-DOPA for absorption. Therefore, the individual will absorb what do you call it? The amino acids in the protein instead of absorbing L-DOPA. They said, please, we should encourage them not to take too much what do you call it? Protein diet when somebody is on L-DOPA. They say patients are generally advised to follow high calorie but low protein diet. Therefore, who is going to give this high calorie, low protein diet is somebody who is in the nutrition department. They say generally, more than 15% of the calories should come, not more than 15% of the calories should come from protein, meaning that they shouldn't put 50% protein. At least they said not more than 15% should come from protein. Then it is only somebody who is in the nutrition department that should be able to design food for somebody who is having Parkinson's disease and on methyl dopa to be on what do you call it? On on 15% protein. They say patients are also advised to increase their daily intake of water and dietary fiber. Therefore, if one is taking cucumber, take everything. They have high dietary fiber. Take carrots. Take food with a lot of fiber, such that it will prevent constipation problem. Then now occupational therapy. They say rigidity and bradykinesia can limit upper extremity feeding movement. Therefore, somebody want to feed, probably it's better you invite the occupational therapy. They said the occupational therapists can also instruct patients on strategies to perform self-care activities using the cup, eating utensils, wearing clothes, brushing teeth. They can do that. They said OT could modify the home environment. Like for example, the toilet is too low, they can modify. The table the patient is sitting, everything occupational therapists can help somebody modify the home environment for the patient. Then we have the speech and language pathologist, also has an important role in the evaluation of dysphagia and the recommendation of strategies to assist swallowing dysfunction. Patient, family, caregiver education should focus on the importance of maintaining good nutritional intake. Therefore, you need speech and language pathologists. We may need speech therapists if somebody is having speech problem. But if he's having dysphagia, you need what? A pathologist that will help him with what? With medications to overcome swallowing problem. Then we now, in conclusion, they said exercise training administered must be timed. This is important. For all periods when the patient is at best. What is the best time for the patient? 45 minutes to 1 hour after medication has been taken. Meaning that if somebody is taking methyl dopa, let him take methyl dopa immediately before he left his home to the clinic. By the time he comes to the clinic, he must have spent 1 hour. Shikenan, you are at best. You would enjoy it, the patient would enjoy it. They say stretching will be more effective if the muscles have been warmed up with active exercise or with an external heating modality. Therefore, before we begin to stretch, before we begin to exercise our patients that are having rigidity, is better. We just do some little rocking exercise, some little, stretches with external, heating with external modality before we do that. They said because the patient with PD already demonstrates too much stiffness, isometric training is contraindicated. Therefore, any form of exercise, even if you are using weight training, you can do it. But don't do a lot of isometric training. Even when we said do prone and raising shoulder, when the patient raises shoulder, let him come down. Let him not hold it so that rigidity of the spine may not persist. Meaning that you can do strength training, but don't be holding such that rigidity cannot be, what do you call it, exaggerated. Queuing is not suitable for patients with what? Severe Parkinson disease and dementia, because they have to respond to command, and then they cannot respond to command based on their condition. Thank you very much for listening.
Thank you, sir, for the in-depth presentation. And,
okay, I can see, let me see, I think there are some comments, go?
Yes, in the text in the box, no? Yeah.
Yes, let me go through the text in the box. We are really sorry for starting late, but hope we didn't have any, what do you call it, network problem.
Yes.
I am trying to load the comments.
Okay.
It's loading.
Okay. Mine is just addition to support what you said. We currently had 2 systematic reviews, which has proven the effectiveness of non-invasive brain stimulation, that's TDCS, especially when it's combined with concurrent dual task training. That's the person doing motor and cognitive, or cognitive and cognitive, or motor and motor. The task has to be dual, and then you now stimulate the DLFC. That is the dorsolateral frontal cortex. So it has shown to significantly improve mobility and balance outcome in older adults. Those with and without Parkinson's. Though the paper is under review, but we have done the review that's shown the effectiveness.
Thank you very much for the input. That shows that in no time, physiotherapists are going to have, what do you call it, the effective, the research, what do you call it, allowing us to use the evidence to use, what do you call it, transcranial magnetic stimulation.
Yes.
So thank you very much.
We had another one, which has also shown the effectiveness of transcranial direct current stimulation combined with treadmill training. This time around. Not dual task. Also under review. It's not being published, but it's on the way. Yes.
Okay, but actually, what is likely the what do you call it? The finding.
Okay, as you load the comment, let me open the paper so that I can show you the conclusion.
Yes, actually, I was trying to load the comments, but I could not load it.
Okay.
Show charts previews. I am trying to show it.
You're supposed to show. Let me if I can read for you.
Okay, please, if you can read for me, please.
Okay, they are there. Somebody say thank you, sir, for the clarity of the exercise.
You said?
Okay, they are all praises.
Okay.
Such flavored presentation, all encompassing. They are all praises for the presentation.
Okay, so thank you, sir.
People have enjoyed the presentation.
You know, at times when I tell my students, when they are making yes.
The other finding is that treadmill training, when it's combined non-invasive brain stimulation, it significantly improved dual task time up and go, and then intracortical inhibition in patients with PD, with Parkinson.
You now see there is something very important. You see, most patients with advanced PD, they used to have problem with dual task performance. But if we initiate this initially, when patients come to us, definitely is going to go a long way improving the cognitive function of these guys and also improve their performance. So thank you, Dr. Samani. You know, you are more current than me. on when it comes to
No.
all these what do you call it, brain stimulations. We really appreciate you and we appreciate your comment. And we can see that there is a lot that physiotherapists can do to patients with Parkinson's disease. The only setback we have is that when the patient is at the initial stage and dopamine or L-dopa can actually take care of most of the motor symptoms, they don't tend to refer the patient to us. And then, but
Yes.
one thing we should understand based on what the literature says, and I think it's one thing we used to do that is I don't know whether we really know it, that we must know when the patient is taking their drugs so that we can see the effectiveness of what we are doing.
Oh, yes.
So I want to appreciate everyone. For those that ask about RPE, there are some things that when you ask, probably the class is a bit advanced from when we say RPE, rate of passive exertion. You can go and read about it's a box scale of 6 to 18 and 0 to 10. There are some things we keep saying. Some people will have to go and be reading. Like somebody was asking about aerobic exercise. Okay, let me talk about aerobic exercise. When we say aerobic exercise, we mean any form of exercise that we use large muscle groups, most especially of either upper and lower limb, to perform, but actually at a slow pace, but for a long period of time, like jogging. You can be jogging for an hour. You are using large muscle groups and you are taking at a slow pace. That is what do you call it? An aerobic exercise. This aerobic exercise utilize oxygen and it improves cardiorespiratory endurance and muscle endurance. That is the answer for aerobic exercise. Okay, I want to tell all members that I also appreciate you. Thank you for waiting for us as we succumb to the problem of what do you call it? Poor network. We really appreciate you until we meet next time. Thank you very much.
Thank you, sir, for the presentation. So any comments? In the absence of comments, we thank everyone for the participation. And this brings us to the end of the neuro cycle of the workshop. So today is the last day for neuro. And next week, we will be entering research workshops, which will run for 3 weeks. Research, how to appraise evidence for critical use and systematic use. And then after next week, we will now enter, after next 3 weeks, we will now go for orthopedics. That is how we keep moving. So thank you, everyone, and see you.
Yes,
Thank you, sir. Allah ya ƙara basira. Mun gode.
Nasib